उन्होंने ਉਹ ਕੀਤਾ।
Hi, am I audible?
Yes, sir, you are audible.
Okay. Could we start?
Yeah.
Okay. Good morning, everybody. My name is Dr. Balwant Singh. It's my pleasure to have you all the esteemed event hosted by UCC conferences. Hopefully, some of you were able to see the sessions that happened yesterday. I, Dr. Balwant Singh, will stand here today as the chairperson of this remarkable Emirates Pathology, Digital Pathology, Cancer and Gastroenterology Conference, humbled by the privilege of addressing such an exceptional gathering of pathology and gastroenterology professionals from around the world. It is an honor to witness the power of collaboration and knowledge sharing that this event represents. UGC conferences serve as a testament to our shared commitment to the noble profession of pathology, digital pathology, gastroenterology as healthcare professionals. We are interested with the care and well-being of individuals and communities, and our roles have never been more vital than in the challenging times we find ourselves in today. Now we will start day 3 session. Our first presenter of day 3 is Dr. Garima Anandani from India. Welcome, Dr. Garima.
Good morning, everyone. Thank you, sir, for the kind introduction. Shall I share my screen now?
Yeah, we can see your screen.
Is my PPT visible now?
Yeah, visible.
Okay. So I'm Dr. Garima Andani. I'm working as an assistant professor in Department of Pathology at AIIMS Rajkot. I have done a meta-analysis on neuropathy in X-linked A-gamma globulinemia. So I would like to present the same. X-linked A-gamma globulinemia or Bruton's disease is a primary immunodeficiency disorder which is diagnosed at a very early age. It's caused by mutations in the BTK gene at the long arm of X chromosome. These mutations are heterogeneous with various heterogeneous variations in the BTK gene. Mature B lymphocytes levels are very low, due to which there is no production of immunoglobulins, and due to which patients are predisposed to mild to severe and fatal infectious as well as non-infectious neuropathies. Hereby, individuals are vulnerable to invasive bacterial infections, but viral infections are also seen. At present, there is no definitive cure for XLA. Early genetic diagnosis and lifelong intravenous immunoglobulin replacement therapy is the most recommended and life-saving treatment. These patients develop a variety of neurological manifestations which can be a presenting feature or a complication in XLA. Meningoencephalitis is a common one of them. This systematic review and meta-analysis was conducted in accordance with the PRISMA guidelines. Protocol had been registered in the Prospero database. Total 436 articles were identified through the PubMed database literature search. This is the summary of what we identified. We identified 436 articles, out of which we did abstract screening and excluded 383 as they were not including the nervous system. Out of that, three of more were excluded as it was not a human study, it was a review article and it was not a case of XLA. So finally, we went forward with 50 articles on this topic. We included case reports, case series involving the newly diagnosed cases of XLA along with the involvement of nervous system. Similarly, we also included known cases of XLA with involvement of nervous system and also original articles. We excluded articles which did not have neuropathies, which were not cases of XLA, which were review or systematic reviews, and non-human studies. So we have collected the data, enlisted them, merged them together, and we encompassed the patient demographic details, age at onset of the symptoms, age at diagnosis of XLA, which neuropathy was present, what was the genetic mutation, information about the pedigree analysis, laboratory parameters, CSF findings, the treatment given, and the outcome. For assessing the risk of selection and measurement bias, for each included article, we categorize them as low, moderate, serious, or critical risk of bias by using a tool proposed by Murad et al. To determine the certainty of evidence in each article, we categorized as high, moderate, low, or very low using the grade assessment. So the dataset included a total of 50 studies encompassing 82 cases manifesting as a wide range of neurological conditions. These were the neurological manifestations in cases of XLA which we have identified. So there was meningitis, including pyogenic, that is bacterial, chronic, enteroviral, or non-specific. Also encephalitis, various infections like enteroviral, tick-borne, viral, estroviral, and non-specific and non-infective encephalitis was also seen. Meningoencephalitis comprises of toctinovirus infection, enteroviral infections, vaccine-induced poliomyelitis, Keki-Valley virus, varicella-zoster virus, and non-specific meningoencephalitis. We also saw myelitis, progressive neurodegenerative diseases, chronic encephalopathies, progressive multifocal leukoencephalopathy, Maury-Trenberg syndrome, von Reckling-Husson disease, and a case of autism. The grade assessment and risk of bias was analyzed. Grade assessment showed that 15 studies had high grade, 28 moderate, 6 studies had low, and 1 study had very low grade. Risk of bias was low for 21 studies, moderate for 24, and high for 5 studies. So this is the pie chart for the grade assessment and risk of bias, the same thing which I showed you previously. The demographic details of the patients were studied, in which 79 cases, that is most of the cases, were males. Only 3 were females, which were categorized as atypical cases of XLA. The age at onset of symptoms varied from 11 weeks to 8 years, and age at diagnosis varied from 11 weeks to 48 years. All cases diagnosed to be XLA in the first few years of life, except 2 cases. One was at 23 years and another at 48 years of age. We have analyzed various laboratory parameters and prepared the forest plots for the serum levels of immunoglobulin G, M, A, E. Also the total leukocyte count, hemoglobin, platelet count, and B cell count across the included studies. The CSF findings as well as the genetic mutations were merged together and analyzed. The family history was also studied, in which we saw the status of the mother. Mother was a carrier in across 10 cases, and in 2 cases mother had normal genetic copies of BTK gene, whereby those 2 cases has de novo mutations. This was the bar diagram analyzing all the age at onset of symptoms. Then we also analyzed the age at diagnosis amongst the cases of XLA with neuropathy. Forest plots were prepared. These are the forest plots of the same. The age of onset of symptoms had a median of 22.5 months, and age at diagnosis of XLA had a median of 36 months throughout the cases. Then the forest plots of IgG showed that median was 96 milligram per dl. For IgM, the median was 8.5 milligram per dl. Similarly, for IgA, the median was 7 milligram per dl, and for IgE, the median was 50.65 milligram per dl. Total WBC count was also analyzed with a median of 11,900, which is mildly elevated. And hemoglobin levels showed a median of 10.3 gram per dl, which is showing a mild anemia. Okay. Now, the forest plot for B cell counts were also prepared, and it showed a median of 0.1 percentage. That's what the B cell count was, less than 1 percentage in all the cases. Also, the platelet count showed a median of 3 lakhs, which was normal. So, in terms of treatment, IVIG was administered in 44 studies out of 50. Other therapeutic interventions, including antiviral drugs, antibiotics, and interferon based therapies, were also used in 4 of the studies. Adjunctive therapies like steroids, physiotherapy, surgical interventions were used in 12 out of 50 studies. Treatment outcomes revealed a mixed response. A good clinical response was observed in 33 studies, that is 66%, while in 13 studies there was deterioration or progression of symptoms. Out of 82 cases, fatality was reported in 14 cases. IVIG therapy was the most used treatment, which yielded a positive clinical outcome in most of the studies, that is 30 out of 44, showing improvement. However, IVIG showed a limited capacity in patients with severe neurodegenerative conditions or chronic progressive encephalitis, where poor or no response were documented. Viral infections such as those caused by enterovirus, esterovirus, tick-borne encephalitis virus showed varied response to IVIG and antiviral therapy. Chronic enteroviral infection showed a poorer prognosis. Poliomyelitis, whether vaccine associated or wild type, will usually responded to IVIG treatment. Non-infective progressive encephalopathy exhibited mixed response to IVIG with some improvement with combined adjunctive therapies. Conditions associated with neurodegeneration like MTS and dystonia Parkinsonism syndromes showed poor outcomes despite treatment. Similarly, patients with IVIG with advanced imaging findings had a poorer prognosis. Mortality rate across the studies was 17%, with higher mortality observed in chronic progressive neurodegenerative diseases or severe infections, particularly those with delayed treatment. IVIG monotherapy was generally less effective in chronic and severe neurodegenerative cases compared to combined treatments involving steroids and antiviral treatments also. So, to conclude, a variety of neurological manifestations can be encountered in cases of XLA. Despite the lack of B cell, a strong CD8 positive T cell response occurs following certain infections, suggesting that these individuals can effectively clear acute viral infections, and upcoming vaccination initiatives may be beneficial for them. Infective conditions respond more positively to treatment compared to non-infective or neurodegenerative cases. Mortality rates were linked primarily to late presentations, delayed treatment. Timely intervention in infectious cases significantly improves the prognosis, highlighting the critical role of early detection and appropriate therapeutic action in managing these conditions. Hence, our study identified important areas of further research in these cases of XLA with neuropathies. The strength of the study is that we included all the studies throughout the advanced search of PubMed database. It encompassed all studies, and reviews were adhered to the PRISMA guideline protocol. Major limitation is the publication bias. As we have collected data from the reported cases with neuropathies, these predominantly comprise of those patients who are hospitalized, and there may be a bias towards severe cases with worse disease outcomes. Thank you for the patient listening.
Thank you, Dr. Garima. Nice demonstration. Any questions from audience? I think there is no questions.
Okay.
Thank you, Dr.
Sir.
Garima. Nice demonstration. Do brief very precisely. Thank you.
Thank you so much.
Now, Our next poster presenter is Dr. Vivian Lunde Daron from Monaco. Dr. Vivian.
Yes, can you hear me?
Presentation on metallurgic substances in mining occupants.
Yes.
Yeah. Please start.
Okay. Hi, everyone. I hope everyone's doing very well. I'm Dr. Vivian Lundy Dadian. I am a physicist, pathologist, and I run a laboratory for pathology. My background is in forensic pathology. Today, I wanted to present something for digital pathology and transition through the presentation to explain to you about the applying the pathology to toxicology and medical images. We're going to discuss a case today, very important, having to do with active minerals and metallurgic substances. So, as we move forward, you can ask me questions. So metallurgic substances usually are presented in mining occupations involving individuals, human beings that work in mining fields. This is very important for digital pathologists because of the microscopic studies they do when they encounter a medical case. A case is labeled as a case, and usually cases are defined by metallurgic substances in interstitial lung tissue, which involves histopathology. Cases involving medical directives, pathology, are associations. Pathology basically is associated with.
Dr. Vivian.
Yes.
Please say her next.
I'm sorry?
Say technical team to next page of your presentation.
Oh, thank you. Sure.
Every time you have to say next.
Okay. So medical directives, pathology are medical directives, and pathology is association with obtaining a license to adhere to standards for treatment. So it's pathology is bringing things together. So to adhere to the standards for treatment and testing, pathology of the actual science that you receive, actual cases, pharmacovigilance, which means receiving a case and drafting a research and treatment, taxonomy based on the international classification of disease. Mining occupations involving material science involve certain mining occupation cases, harmful substances, hazardous chemicals, metallic minerals that are not supposed to be embedded into tissues of the body. Again, histology, molecular analysis of a substance, which involves a lot of microscopic pathology. So the easiest way to remember this in mnemonics, if you're a digital pathologist, is the 3-tier system: prognosing, diagnosing, and then testing. Next page, please. Digital pathology cases. Over here, I identified one case that I synchronized with my research. Over here, we see spatial data that was taken from a microscopic approach with digital pathology equipment. This case also involves some radiology. Radiology can, certain types of radiology equipment can capture microorganisms or micrometallic substances. So this case is a pleural cavity. As you can see in A, B, and C, we have the scan, and then we have the microscopic image at the bottom. And this shows you the the mining occupation case involving digital pathology, if you're going to be creating a case record, you would need to illustrate certain things that are in the case. So over here, we see the metallic substance in blue that was captured through a transitional pathology lab. So it transitions into more of a micro level to capture the material. And we do use stains. This is also showing you how the substance is embedded in the photography illustration provided from the case. And another thing is that if you're using a proper system, all the work that you do on a case gets captured into an algorithm, so you never lose your data. Next page, please. Digital pathology cases with medical images. Over here, I show what the digital pathologists do. Pathology, microscopic. It could apply to any part of the body. Mostly the case that I was very interested in was in the mining occupations for capturing metallurgic substances at a microscopic level in tissue. Because I started becoming very aware that studying tissue histopathology, forensic pathology was very important in synchronizing that with toxicology. So over here, I show you what a basic digital pathologist's office looks like. It is a physician's office, such as mine, and it is a laboratory, it is a clinic. Sometimes we do non-clinical and we also do clinical. Non-clinical would be testing substances to match them to a medical case. So we do specimen collection, application of case, substance UIPAC number if you're using laboratory chemicals. Laboratory chemicals could be found in ECHA. ECHA is a website that gives you the chemicals that you work with in the laboratory for pathology, for forensic pathology, microscopic pathology. You apply the materials and then you would disrupt the normal actual damage to the tissue. You disrupt it by staining it, and this creates a image for you, an abstract. And as you can see, you could zoom in and zoom out. You could do a microscopic, you could do x-rays like I showed in the previous slide. You would prognose the case, you would test the case and provide research conclusions. For example, in these occupations for industrial workers who work in mines, who work in petroleum, gas, oil, they get injured sometimes without any warning. So basically, digital pathologists or any doctor that works in industrial medicine would have to find out what exactly the case was. I did work on a case like that, and that made me more interested into histopathology, the materials, the mining materials, the metallurgic substances. Certain areas of occupational hazards involve a digital pathologist that is not available on site, but that could virtually, remotely help the patient. For example, these patients that come through with industrial injuries. Next page, please. So digital computational pathology, you have to compute all of your work. You have to do your mathematics, your physics, which if you completed your master's degree, let's say in biomedical engineering or microbiology, you probably became a forensic pathologist or a digital pathologist specializing in technology. I specialized in digital forensics. So I studied all types of methods. Now, to become more focused on the digital aspect of pathology, this digital pathology concludes these were certain environmental factors digital pathologists study. They apply it to interpretations, strategies, and diagnostic interpretations and issues. Consultations can be done with digital pathologists with the proper medical imaging. Biometrics is what saves your data. We all know what pathology can do. It could create a lot of files that we need to downsize and keep. Values, standards, issues unique to pathology, and then valuing and standardizing your digital pathology lab is important as well. You could categorize things into metallic substances, forensics, or you could categorize them into environmental hazards, computational pathology versus digital pathology overrides predisposed microbiology standards. This involves a computational system where you input substances and it gives you the chemical orientation, it gives you the molar value, the weight, it gives you the basically the chemical calculations. It tells you how many slides you reviewed. So this is more of a computational system. If you link this with your digital pathology, it works out great from my experience. If you use both of them together, it's very rational. Complex cases for setting up archives. Complex cases, anyone who is a pathologist knows that pathology involves really, really looking at slides and really studying the case and really getting all of your case notes and all of your evidence. So pathology is really based on a lot of evidence. So, optimistically speaking, this is something that I have successfully encountered, certain things that I have noted that are ways to be successful. And for the future, pathologists and toxicologists are very important because they go through a lot of different substances, even bodily fluids involving blood, involving certain catalysts, involving certain tissues. So they are very important in the international field of research and medicine because pathologists with their computational pathology can provide predisposed medical directives. Next page, please. Next page, please. Conclusive findings in digital pathology. Digital pathology involves environmental factors, applied interpretations, interpreting reports, diagnostic interpretations. It involves doing consultations, prognosis, looking at lab reports, going through certain reports that are scanned into the system. Also, cases involving, like this particular case, involving the pleural cavity, the lung tissue, and the thoracic cavities. That's very important This case involved a lot of pulmonology and pathology together. Biometrics, again, biometrics is about data, uh, valuation, standard issues, digital pathology. Digital pathology systems involve creating a record of complex cases and making sure all of your research is documented appropriately and making sure that your computational system is others can comprehend it well because we work in an international environment. Next page, please. Key points I wanted to mention. So some keywords just to revisit from the beginning of my introduction to the pedagogy of um, uh, mining occupations, digital pathology, and metallurgic substances. Some key terms we discussed in this presentation. We discussed digital pathology. We discussed pedagogy. Pedagogy is how we associate things together. Quantitative pathology, computational pathology, diagnosing cases based on lab reports, toxicology. This particular case involved a lung tissue, which I illustrated. MRI, CT, PET scans can be used as well. My objective here was to provide safety to workers who work in the industrial industry in any country in the world, where they work in mining sites, they work with substances, they work in geographical sites, they work in the desert, they work in certain areas where, you know, they get injured. And, you know, this particular case involved a work injury in more of a rational terms, we call it industrial injury. So, um, you know, physicians partner up with digital pathologists, toxicologists, those specializing in diagnosing these certain cases. So over here, I mentioned coal factories, I mentioned environmental workers. So the digital pathology is very important also in toxicology. Toxicology, from my experience with digital pathology, where I first had to do a case, um, and I'm talking to you from Monaco right now, the Mediterranean, near the Mediterranean Sea, but I worked on a case in Boston, Massachusetts, where it involved forensics. So that's where I developed my skills for digital pathology and toxicology. So the pedagogy of associating those two provided me a wealth of knowledge. And I wanted to share that with you. And I'm so happy I'm here today sharing that with you. I'm happy that I had an opportunity to help other pathologists maybe see the light into my microscope. So these environments, industrial, metallurgic substances, environments such as certain areas of Europe, the Mediterranean or Middle East, ports, harbors, mining sites. And so these areas is where most of the digital pathologists cannot actually go to the site and do an excavation. They have to remain in their professional environment, in a safe environment, and be provided certain diagnostic material. Experimental analysis, that's done in toxicology. We do experiment with substances. Either we have them in the lab as specimens, or it's provided to us through a case report or a new case. Next slide, please. Key points. Case summary in this manuscript is basically to provide you with the wealth of knowledge. If I could speak more about this issue, in the future, we're going to be shown certain cases that we haven't seen before, especially digital pathologists see new cases every month. Digital pathologist, toxicologist, histo pathologist, those specializing in microscopic medicine, those specializing in mining, metallurgic substances, specializing in having a wealth of knowledge in metallurgic substances and how to capture them in order to provide a prognosis, treatment plan, and to provide some industrial medical directives on how to prevent these injuries, how to go about your occupation without being exposed to hazardous material and such. Conclusions to this presentation, I will provide you certain conclusions I wanted to make is that digital pathology is very important. It's very important to be very discreet about the associations you make with your either it's your digital pathology or your computational analysis or it's your pathology and toxicology. I provided some references for you. I provided some organizations that also helped me, and I have provided some acknowledgments that helped me. And I really wanted to thank them for helping me with the technical writing and providing you with this information and being here today. I feel that it's very important that we move forward in advancing in this microscopic science into studying metallurgic substances and also kind of transitioning into certain other types of industrial medicine where we could treat a patient by being attentive to the case and by providing certain organized data for the substances that we collect, making sure that every year, every month, we advance, we check in, we look at new cases and look at new injuries. How are these injuries happening? Make the pedagogy into associate them and see how these things are developing and how we could provide with our pathology skills, how we could provide them with a safer environment because they provide us with a lot of industrial types of things that we don't think about day in and day out. And so, having patients, with those types of injuries really really makes me want to advance more and look into the cases more. And I really, after getting more, I always am learning. So, and I always love to share with people what I learned. And I'm so happy to be here today. Next page, please. So if you wanted a copy of this presentation, you can ask the organizers of this conference, and I give them permission to share a copy with you. And you could take it to your desk, to your office as a checklist if you enjoyed it. Certain international standards I quoted here that are standard for laboratory. The main one is the international standard for 15189. One thing that I'm working on moving forward for 2025, 2026 is ATMP for these types of injuries. So ATMP is an advanced therapeutic medicinal product that is manufactured with the help of digital pathology, and it provides a new type of treatment for a certain type of diagnosis that we diagnose through ICD, International Classification of Disease. I'm also going to be moving further with the metallurgic substances with certain vector control products. So those are certain types of products that I see in the digital pathology lab, toxicology lab. I do look at metallurgic substances, and I still look at mining occupations, but these uh, these types of these types of cases involve airborne. So I will be focusing on that. That is usually involves a team of people that come together to create and manufacture a new treatment with medicinal, therapeutic medicinal. So my laboratory is Lofton Clinical Laboratories. I work with others, but I am the director. I have a business license, so I own it. I have done my training, but I never stop learning. My mind is always open. I'm always open to share with people. Um, I focus on um, molecular. I was focusing on molecular biology, molecular diagnostics, and I traveled to certain areas, and I work with team of people from different areas. Jane Mayen is in the Norwegian Sea. Federal Island States is in the Pacific. Right now, we're in the Mediterranean. But these are certain locations. Now, moving on from the locations, I'm affiliated with certain affiliations I have. One thing I didn't list here was the Australian Microscopic Society. And I didn't list that because I had just been introduced as a member to that society. The European Chemical Society is very important. I recommend any pathologist that works with chemical substances to do stains on on their slides, or certain things that involve capturing or disrupting the cell to provide you with the diagnostic image that you need. These societies might be far away from you, but being a professional in the international environment, you could utilize it. You could utilize it because it involves the intellectual properties that you carry, and how you bring that together into the international community. We all provide, we all put in our best efforts to help advance this field of digital pathology, and basically, to sum up my experience, industrial medicine and treating people who get injured at work. Next slide, please. Okay, so if anyone has any questions for me, my email address is listed. I have a website called Unilabs Biophysics. That is Lofton Epigenetics Lab. I am Dr. Vivian Lundy Dayden, and I'm an MD. And I wanted to mention that I will be continuing my work into digital pathology. I will be working on a new ATMP, an advanced therapeutic medicinal product for those who get disabled or permanently disabled through industrial injuries. Um, I wanted to conclude this pathology on metallurgic substances. Again, if you have any questions about what a metallurgic substance is, you could, I just gave you a wealth of information. I don't expect you to remember everything from this presentation, but if you have any questions, please feel free to reach out to me. I'm more than happy to answer your questions. This was a new approach to digital pathology involving toxic substances, metallurgic substances, and there's a lot of different ones. So, again, my company is listed there. I am Dr. Dayton. Uh, my company is Lofton Epigenetics Corporation, and we have partnerships, and we are available during the UCG Congress conference by email. I know today is the day where we do our conclusions as physicians and scientists, but this conference has brought us together so that we could discuss certain things. And in the future, hopefully, we could attend the same conference with new ideas, new innovations, possibly new cases to discuss. And I wanted to thank you so much for allowing me to speak to you today. I am very grateful for your time and for your attention. Thank you very much.
Thank you, Dr. Vivian. Any questions from audience? I think there is no questions. Again, thank you very much, Dr. Vivian. Nice presentation. Now our next poster presenter is Dr. Sukanya Ghosh from India. I would like to invite Dr. Sukanya to present her presentation of EZH2, an epigenetic regulator, as a novel prognostic biomarker in invasive breast carcinoma. Single
Am I
center.
audible?
Yeah.
Okay, I'll share my screen right away. Yeah. Okay. I am Dr. Shukanya Ghosh, presently posted in ESI Maniktola, pathologist from Kolkata. Am I audible?
Yeah.
Yeah. Today I am going to speak about EZH2. EZH2, an epigenetic regulator, as a novel prognostic biomarker in invasive breast carcinoma, a single center analysis. Now, breast carcinoma is comprised of a variety of disease entities bearing diverse pathological features, prognostic outcomes, and metastatic behaviors. Understanding
Dr. Sukanya,
how.
not, your screen is not visual.
Can you share my PPT, please?
Technical team is sharing.
Yeah, please share my PPT.
Yeah. You are
Okay, next slide, please. Okay. Breast cancer is comprised of a variety of disease entities bearing diverse pathological features, prognostic outcomes, and metastatic behavior. Now, understanding how the breast cancer cells disseminate and metastasize is essential for more efficacious treatment and to improve survival. Now, although breast cancer is an epithelial malignancy arising in the epithelial cells of the terminal ductal lobular unit, the surrounding stroma and its interplay with the tumor is of utmost importance in deciding the tumor behavior and progression. Studying this interaction may contribute to finding new and effective methods of treatment. It has been proved beyond doubt that tissue microenvironment play an important role in controlling the cell survival, proliferation, migration, polarization, and differentiation. Many studies have tried to identify biomarkers for novel therapeutic purposes in various human cancers, but their success has been limited. Thus, effective novel biomarker remains a topic of great clinical interest. Now, breast carcinoma is an extraordinarily diverse group in terms of histomorphology and clinical behavior. They can be classified according to immunophenotypic features, which basically is the expression of ER, PR, and hard to know. Now, triple negative breast cancer has attracted much interest as it does not benefit from any currently available anti-endocrine and anti-HER2 treatment. It is necessary to identify a specific biomarker for treating this unique subgroup of breast carcinoma. Now, breast cancer initiating cells have been identified as cells responsible for tumor initiation, which potentially drive tumor growth and metastasis. Although these statements are still a subject of debate, now our topic of concern is EZH2, that is enhancer of GESTI homolog 2, a histone 3-methyl transferase which correlates with aggressive behavior of many tumors and emerging as a promising target of molecular therapy. EZH2 belongs to the polycomb group of proteins PCG, which is involved in chromatin modifying complexes and stem cell self-renewal. It is a member of the polycomb group of proteins. It is identified as regulator of body patterning by silencing homeotic genes, that is Hox genes in Drosophila melanogaster. It is a repressor involved in controlling the cellular memory and transcriptional silencing. Now, the association of EZH2 with breast cancer was reported back in 2003. The core protein of polycomb repressive complex 2 controls the demethylation and trimethylation of list 27 of histone H3. Okay, next slide please. Okay, the PCG protein belong to at least two multimeric complexes. The polycomb repressive complex 1, that is PRC1, and the embryonic ectoderm development, that is enhancer of GESTI homolog 2 EED EZH2. The EED protein interacts directly with type 1 histone deacetylase in mammalian cells, and this is implicated to be a part of the silencing mechanism. And K27 in vitro with a strong predilection for K27. Methylation of both H3K9 and H3K27 is thought to be associated with the repression of nearby genes via the formation of heterochromatic regions. Now, EZH2, the histone methyl transferase and main subunit of polycomb repressive complex 2, PRC2, that mediates epigenetic silencing of target genes via trimethylating histone H3 at lysine 27, that is H3K27Me3, in the presence of other subunits like embryonic ectoderm development EED, suppressor of GEST12, that is SUS12, and retinoblastoma binding protein, that is RBBPR7, has been found to overexpress in a variety of malignancies. It appears to be closely associated with high proliferation rate and aggressive tumor subgroups, resulting in worse clinical outcome thereafter. Now, trimethylation of H3K27 is an epigenetic label mediating gene silencing, and can function as a marker of the de novo DNA methylation in cancer cells by recruitment of DNA methyl transferase, that is DNMT-TS. Now, EZH2 is a marker linked to transcriptional silencing. Due to its role in regulating fundamental cellular processes like cell cycle regulation, differentiation, and senescence, EZH2 has been thought to contribute to malignant transformation. However, this view has been challenged, and it has been suggested that high EZH2 is a consequence rather than a cause of cancer. Aberrant expression of EZH2 has been linked significantly to cell cycle progression and increased tumor cell proliferation in various types of cancer. EZH2 reportedly is implicated in cancer initiation and in the progression of a variety of human malignancies. Excessive EZH2 concentrations have been reported in aggressive breast cancer and associated with invasion and cancer progressiveness. EZH2 levels were elevated in patients with invasive breast carcinoma relative to a normal or atypical hyperplasia. EZH2 plays an important role in many cellular processes such as cell cycle regulation, proliferation, apoptosis, tumorigenesis, and drug resistance. EZH2 has decisive roles in immune cells like T cells, natural killer cells, dendritic cells, and macrophages, which are essential component in tumor microenvironment. It has been previously identified that overexpression of EZH2 as a potential factor involved in therapy resistance. EZH2 protein has been associated with a high histological grade and worse survival, suggesting its promising role as a prognostic biomarker for aggressive breast cancer. Increased levels of EZH2, a critical regulator of cellular memory, signal the presence of metastasis and poor outcome in breast cancer patients. EZH2 is implicated in cancer cell proliferation, invasion, as well as metastasis. EZH2 is highly expressed in cancer stem cells in a number of malignancies and implicated to have a critical role in cancer stem cell expansion and maintenance. TNBCs, that is triple negative breast cancer cells, lack expression of any of the hormonal receptors, namely ER, PR, and HER2/neu. Now, TNBC patients are amenable only to chemotherapy as a systemic options and have an inferior overall outcome. Expression of epigenetic regulators might alternatively serve as actionable oncogenic principles in TNBC, and their inhibitors might bear significant potential for their treatment. Next slide, please. Now, the aims and objectives of my study were to compare EZH2 expression in different immunophenotypes of breast cancer and the overexpression of EZH2 in triple negative breast carcinoma. Now, a cross-sectional study was done in collaboration with the Department of Pathology and the Department of General Surgery in my college over a period of 1 year. Now, the population were the patients attending both these departments, the General Surgery Department, over this period of time. So, what were my inclusion criteria? These were epithelial breast tumor with known estrogen, progesterone, human epidermal growth factor 2 receptor expression, and Ki67 expression. And my exclusion criteria were benign breast lesion, history of trauma or stromal tumor, history of previous chemo or radiotherapy for other type of cancer, history of neoadjuvant chemotherapy or radiotherapy in breast carcinoma, and there were about total 41 cases, and the control of normal kidney were taken. Next slide, please. Next slide, please. Methods of data collection. Now, the breast carcinoma mastectomy specimens were collected after taking proper institutional ethical clearance from the operation theatre of general surgery along with routine investigation reports. Now, histopathology and immunohistochemistry of EZH2 in formalin preserved paraffin embedded tissue were done in the Department of Pathology. Now, EZH2 levels measured by semi-quantitative method using immunohistochemistry. Now, results were compared with hormone receptor level results. The estrogen and progesterone receptors were measured with Ulrich scoring method, and it was based on the assessment of proportion and intensity of staining. And HER2 scoring was done based on staining pattern as per the CAP protocol. Next slide, please. Now, results were as follows. Out of the 41 cases, 2 cases were luminal A, 9 cases are luminal B, 3 cases were HER2 enriched, and 2 cases were triple negative. And by luminal A, I mean ER positive, PR positive, Ki67 low, and HER2 negative. By luminal B, I mean ER positive, PR positive, Ki67 high, and HER2 positive. By HER2 enriched, I mean HER2 positive, whereas ER and PR are negative. And triple negative, as we know, all are negative. Okay, so as the Ki67 level increased, there is increased expression of EZH2. Like where it was 10%, the EZH2 expression was only 20%, and it increased like that. When it was 30%, it was 50%, and when it increased to 80%, the EZH2 levels rose to about 90%. So we see it is directly proportional. The Ki67 expression is directly proportional to the expression of EZH2 and vice versa. Next slide, please. Okay. Also, when we did the Bloom-Richardson grading, we saw the EZH2 expression was directly proportional to the grading of the tumor. And what is Bloom-Richardson grading? It is depends on the 3 criteria: tubule formation, nuclear pleomorphism, and mitotic count. Points 1 to 3 of tubule formation is given to greater than 75% of the tumor having tubules, 10 to 75% of the tumor having tubules, and less than 10% of the tumor having tubules. And nuclear pleomorphism, 1 point is given to minimal nuclear variation, 2 point is given to moderate nuclear variation, and 3 point is given to marked nuclear variation. And coming to mitotic count, 1 point is given to 0 to 5 mitosis per 10 high power field, 2 point is given to 6 to 11 mitosis per 10 high power field, and 11 plus mitosis per 10 high power field is given 3 points. So when you get the score of 3 to 5 points, we can call it as well differentiated or grade 1. 6 to 7 points, we call it as moderately differentiated or grade 2. And 8 to 9 points, we call it as poorly differentiated or grade 3. So we saw as the EZH2 increased according to the histology grading of the tumor. So the grade 3 tumor had maximum EZH2 expression. Next slide, please. Okay. So we saw the triple negative breast carcinoma is having the highest EZH2 expression, whereas ER positive status having very low expression, followed by HER2 positive and triple negative. Next slide, please. Now, as I told, the association of expression of EZH2 with proliferative index, Ki67 and EZH2 expression have positive correlation, that is, it is equal to 0.424. ER positive breast cancers with low proliferative index less than 15% showed lower expression of EZH2, and triple negative breast carcinoma showed highest expression of EZH2. Next slide, please. Okay. According to the review of literature, we got the following studies. TNYC et al. Said high expression of EZH2 is strongly associated with TNBC phenotype as compared to other non-TNBC. Huang et al. Said EZH2 has been identified as an important oncoprotein associated with the growth of TNBC cells, and Selina et al. Said EZH2 levels can be used to identify patients with breast cancer of a more aggressive phenotype. Now, however, 1 or 2 studies showed discordance, like Mishra et al. Said the expression of EZH2 was increased in malignant tumors and that it promoted anchorage independence and invasive growth in vitro, affecting the proliferation rate to a lesser extent. Next slide, please. So to conclude, we can say that high EZH2 expression is associated with higher grade of breast carcinoma. It is overexpressed in triple negative breast cancer, for which there are no effective treatment options till now. And EZH2 is a promising biomarker of aggressive breast cancer, suggesting that EZH2 may have a role in cancer progression in hormonally regulated breast carcinomas. Now, The most important part, if we target EZH2 in combination of important breast cancer regulators, it will definitely add to some significant steps in combating breast carcinoma. Next slide, please. So this is all. These are my reference. Thank you so much for giving me the opportunity to speak in front of you. So any questions?
Thank you. Thank you very much, Dr. Sukanya Ghosh.
Thank you so much.
Nice presentation.
Yeah.
Our next poster presenter is Dr. Rohit Mathur from United Kingdom. I would like to invite Dr. Rohit Mathur to present his presentation on a large duodenal polyp, Brunner gland hematoma of the duodenum. Dr. Mathur, are you there?
Good morning. Yes, I am here. Just a second. I'm trying to share. Um, Sorry. Can you just share my slides, please? I couldn't able to share it from here. Are you able to hear me?
Yeah. You are audible.
Can you please share my slides? Thank you.
Share your screen, Dr. Mathur.
Sorry.
Share your presentation PPT.
I'm trying, but I think I couldn't do it from here. It's not giving an access. That's a problem. Can you share my slides, please?
Technical team, please. Dr. Mathur, kindly click on share button.
Yes, I'm doing that. Yes, let me check here. This. And, can you see my laptop?
Yeah, you are visible.
And can you see my slides now? Okay. Okay. So
Please start.
good morning, all. I'm Dr. Mathur. I'm the consultant Gastro in East Kent University in United Kingdom. My idea behind is sharing my slides today is to just give knowledge about the one of the rare case we encountered recently in our endoscopy unit. It's about the duodenal polyp. Okay, so I have nothing to disclose. So she is a lady with a 74-year with Asian background, came with the epigastric abdominal discomfort, pain, and gastroesophageal reflux disease symptoms for last 3 to 4 months, and she was on PPI. So we plan to do an endoscopy for her to rule out any other sinister pathology. She doesn't have any other concerning features such as hematemesis, melena, or jaundice, although we encountered pallor and mild epigastric tenderness. Her hemoglobin was found to be 110 with everything normal. Um, then the endoscopy unit, we found a large cylindrical polyp. As you can see it, it is starting from somewhere in D1 and it is extending beyond that. So it's a long cylindrical pedunculated polyp of around 5 to 6 centimeter that appear to arise from first part of the duodenum into the second and beyond that. We took biopsy and it came as, surprisingly, it came as brunoma. The histology has confirmed later, which is showing the lobular proliferation of benign submucous glands. I'm sure they're quite a pathologist here and they understand what it is. Then the next scan, we did a CT scan following this to see whether it is really extending from the mucosa, submucosa, or in the muscular layer. And you can see it is arising just below the submucosa here and with partial luminal narrowing. We treated it with endoscopic mucosal resection in the King's College London, and then the biopsy came as brunoma. So the case was simple, but it's mainly to focus on that every polyp is not malignant polyp. So brunoma gland is basically a normal gland in the duodenum, and it was first described by Brunner in 1688, and the curve here is 1835 has described brunal gland adenoma. So it accounts for 10 to 11% of all non-malignant duodenal tumors. Although there are no malignant potential clinically, but there are some autopsies and there are some case reports where it has showed some malignant potential, very, very rare. So Brunner gland are the branching glands, and it's arising from the duodenal submucosa with primary function of prevention of injury in terms of the acid coming from the stomach. According to the American Society of Radiology, they have described Brunel gland hematoma when they found it is more than 5 mm in size. The most common location is obviously 70% of it is found in the duodenal bulb, in the posterior medial wall, and the next is second part of the duodenum, and the third one is third part of the duodenum. So it all is commonly seen up to 5 to 6 decades. In our case, it is a little bit later, like it is 74. Probably she came in a late presentation because they are asymptomatic. They don't have any gender prediction, so obviously she is female in our case. Um, this could be polypoid lesion or it could be pedunculated, but most of them are pedunculated lesions. Clinical presentation is mainly asymptomatic, and that's what in our case. The anemia was not due to the Brunel gland in our case, it is mainly because of some other gynecological issues. So some cases has presented with bleeding, but in our case there was no bleeding at all. 50% of the cases has been identified as small bowel obstruction when they are too large, causing obstruction in D1 or D2 can cause this one. And very rarely it can lead to intussusception. So these are the beautiful slide where what are the differentials we can encounter when you see a polyp in the duodenum. So it could be adenoma. As for example, duodenum, we have a lot of adenomas we encountered because of either it is a solitary lesions or it can be associated with multiple polyposis syndrome like Peutz-Jeghers syndromes. You can encounter other polyps in case of IC junction like lipoma Leiomyoma, particularly, it is more common in jejunum. You see encountered just in the stomach, which is exophytic lesion and it's very heterogeneous mass. It is very hypervascular. We can encounter carcinoid lesions in the distal ileum. We encountered lymphoma, particularly terminal ileum, and adenocarcinoma in the duodenum. So most of the Brunner gland has not identified a clear etiology, but we have some postulated theory. Is particularly the hyperacidity syndrome. Hyperacidity causes more Brunner gland hyperplasia, and other like mucosal injury, H. pylori infections, chronic pancreatitis, and any other inflammatory stimulation. So this is the wonderful case series where they have taken all the glands and associated with H. pylori infection. As you can see, it most of this case series has identified association with H. pylori infection, and except one case series. So Brunner gland hematomas or adenomas are not new to us, but is mainly to focus on the um, to see that it is not a malignant one. Treatment options are quite simple. If it is very small, we can do an endoscopic polypectomy. And if it is large pedunculated polyp, obviously laparoscopic removal, particularly when you are concerned about its morphology and whether you are concerned about its extension beyond submucosa sometimes. So yes, so if it is a surgical options, if it is obstructing or came into intussusception, then probably you will go and end up into pancreatic tubectomy. So yes, so this is my all about this slide. These are my references. Basically, the key point is the not every duodenal polyp is a malignant polyp. Sometimes you don't even remove it if you have definitive benign evidence. Yes, and but obviously it is always better to remove it because they tend to grow more and more, and then it causes partial obstructions and anemias. So that's all about my slides. Thank you very much. Any questions for me? I am happy to answer. Obviously, there are a lot of pathologists, so I'm not a very expert in giving you about the detailed slide explanation. But yes, I can give you some endoscopic advice and all these things. Thank you.
Dr. Mathur, one question.
Yes, please.
Dr. Mathur, we routinely do EMR of polyps. Major type of risk which you have faced in EMR of large polyp?
Okay, so if you have large polyp, the first concern is the extension of the polyp beyond the mucosa and submucosa. But if you are free enough by doing CT scan or endoscopic ultrasound, whatever modalities you are available having there, the perforation risk is high, the bleeding
It
risk is
might be
high.
major risk would be perforation.
Yes, yes. The perforation and obviously yes. Particularly when you are dealing with on the the medial side, and it's very difficult to close even then. So that is yeah.
And second question is recurrence rate of Brunner gland adenoma after EMR.
So although there is no documentation of its recurrence, but it can reoccur because when you are doing one polyp, you might miss another small polyp besides it. So you can always miss it, but it's not always um, its the recurrence is not in relation to the cancer thing. So like if you are removing some adenomatous polyp who has malignant potential, there are obviously risks when we are doing colonoscopies and multiple in cancer surveillance pathway, but it's not like that in the brunneroma. So because it is a benign nature, very rarely there are some case series, one or two I think, which has reported malignant potential, and in that case series also they are not very sure about it. Yes.
Thank you, Dr. Mathur.
Thank you very much.
Now we will take a coffee break of 20 minutes. All participants Now we will take a coffee break for 20 minutes. We will join after 20 minutes. Thank you. Hello everyone, welcome our break. After break, our next poster presenter is Dr. John Felix P. Lyser from the Philippines. I would like to invite Dr. John Felix to present his presentation on Stuck in the Middle, a case of superior mesenteric artery syndrome on a 68-year-old male. Dr. John?
Hi, I'm just going to share my slides. Can you see my slides?
Yeah. You are visual now.
So, good afternoon, everyone. I am Dr. John Felix Alicer. I'm from the Philippines. Together with me is my attending physician, Dr. Jodulfo Barnuevo. I am currently the chief president of our institution here in Davao Doctors Hospital in Davao City, Philippines. So today I'll be presenting one of the cases you don't see every day, and one of the cases you won't be handling regularly. Presentation titled Stuck in the Middle is a case of a 68-year-old male who was diagnosed with upper GI obstruction, a case of superior mesenteric artery syndrome. So this is a case of patient AM. He is a 68-year-old male. He is a known diabetic who came in due to villous vomiting. History started 1 year prior when the patient had the onset of postprandial villus vomiting associated with early satiety. Initially sought internist and was managed as a case of diabetic gastropathy and was only given meprazole and metoclopramide, which afforded only temporary relief. However, 3 months prior, the patient had the onset of new symptoms, now associated with weight loss and inability to tolerate solid food. He also had severe episodes of anorexia and had the fear of food intake. He was worked up in an institution outside Davao City in one of the provinces of the Philippines, where an upper GI endoscopy was done, only revealing severe esophagitis. A colonoscopy and snare polypectomy was done, only revealing solitary rectal polyp, which was known to be benign, and grade 1 internal hemorrhoids. So, inconclusive diagnosis, they proceeded with a CT scan of the whole abdomen, again, only revealing atherosclerosis and spondylosis deformans. The internist didn't know what to do from her end because the patient's symptoms were progressive and medical management wasn't doing anything for the patient. So the patient was maintained on soft diet and nutritional buildup was done, and he was referred to our service here in Davao Doctors Hospital. So for the past medical history, he's only a known diabetic. He's non-hypertensive with no previous surgeries. Family history is pertinent for diabetes and hypertension. And he is known to be a retired businessman with no food and drug allergies. 70 to 80 with an ECOG score of 1. So upon physical examination, the following were found. The patient was awake, comfortable, slightly asthenic with a BMI of 90.8. Abdominal exam was soft, scaphoid with non-distended, non-tender, and normal active bowel sounds. So the imaging done outside of our institution was then reviewed by our friends in radiology here, and I think they failed to note the following important findings. So upon reviewing the images, if you can see in your screens, you can see the D3 is compressed in between the aorta and the SMA. So this can be appreciated in the coronal view. The impression of our radiologists here in our institution is upper GI obstruction, likely secondary to mesenteric artery syndrome. As you can see, the proximal portion of the duodenum, these are D2 and D3, is severely dilated with air fluid levels. Going distally, it becomes more collapsed here, which you can appreciate. Now, according to an article by Gans et al., um, a normal aortomesenteric angle is 38 to 65 degrees. In instances where it is less than 25, this will decrease then further the aortomesenteric distance, which is less than 10 mm. This would now cause compression to the third part of the duodenum. Sometimes this can either be congenital or acquired. So you can see that clearly here in our, this is a study. Then you can see the inflammatory changes for duodenal fat stranding around uh, third portion and fourth portion of the duodenum, where you can find the SMA. So here you can clearly see the AOMD and the AOMA, which are the important parameters to consider when you diagnose SMA syndrome by imaging. So here you can see the AOMD is 7.4. The AOMA is 46 degrees. However, it seems to be normal, but if you look at this AOMD, it's quite small. So this would then qualify to our impression, which is upper GI obstruction secondary to SMA syndrome. Now, pre-op patient optimization and workup was done, and all lab results were within normal limits. So initially, the patient was uh, resuscitated with fluids, started on electrolyte correction prior to doing any procedure, and NGT was also done for decompression. So what are the surgical options we can do in cases like this? So the three most common options are the following. You have your gastrojejunostomy, duodenojejunectomy, and the strong procedure. Now, gastrojejunostomy is a bypass procedure wherein to create an side-to-side or end-to-side anastomosis in between the stomach and the jejunum. Another option would be doing a bypass using your duodenum and your jejunum. So this is a duodenoj or duodenojejunostomy, anastomosing D3 to your distal jejunum, usually approximately 40 cm from the ligament of Treitz. Another procedure that some surgeons do is what we call the strong procedure, in which they cut or divide the ligament of Treitz to release attachments of the jejunum from the to release it from its uh, being compressed from the SMA. So the plan done for this patient was an open duodenectomy. This was more common and most studied procedure when it comes to SMA syndrome. So intraoperatively, we noted the following. So you can see here D2 is quite dilated. D2 and D3 are, and your D3 and D4 are almost collapsed. SMA was noted here, clearly pointed by the instrument, is compressing this portion of the duodenum. So what we did is we created an anastomosis, a duodenojejunectomy, in between two structures, creating a bypass channel for fluid to go in. Post-operatively, patient had a remarkable course in the wards. So the patient was progressed to sips of water on day 3, general liquids on day 4, soft diet on day 5, was discharged on day 6. Now, upon follow-up, the patient had tolerated already solid food. The patient had no recurrence of nausea and vomiting. He had weight gain of approximately 6 kilograms since the procedure, and the patient notably had an improved quality of life. So with that, I am happy to report uh, not so common cases with only an incidence of 0.1 to 3%. So we were quite lucky to encounter this case in our institution, and I hope it may help shed more light within uh, the rarity of this syndrome and its management. So that would be all. Thank you. These are my references. Thank you. Do you have any questions?
Thank you very much, Dr. John. Our next poster presenter is Mrs. Silvia Solana Elias from Argentina. I would like to invite Dr. Silvia to present her presentation on type
Thank you very much.
Frozen syndrome case report.
Now I'm sharing my screen.
Share your PPT.
It's okay? You can see?
Yeah, you are visible now.
Oh, I'm sorry. At the end. Okay, good morning, everyone. My name is Solana Elias. I'm doctor at Hospital Universitario Austral in Buenos Aires, Argentina. Today I'm presenting a case report of a patient with type 2 achalasia with associated with the Sjögren syndrome. As introduction, the primary Sjögren syndrome is a slowly progressive autoimmune disorder that affects 20 times more women than men. There is limited information regarding this pathology in Latin American population. It is approximately a 3% of population that could be affected. This disease may evolve affecting various organs and systems. Respect gastrointestinal symptoms are very common in primary Sjögren syndrome, like disorders in peristalsis, significantly reduced salivary secretion, and difficulty in swallowing and bolus progression. Our case report is a female patient of 66 years old. Her medical record, she had ocular dryness since 2005, insulin resistance in 2018, now controlled without medication with a glycosylated hemoglobin of 5.6%. She also had arthralgias since 2021, evaluated by rheumatologists, showing then only a positive ANA with speckled pattern 1 in 19, and she also had a COVID-19 infection in 2021. In 2022, a thymic cyst was resected after being incidentally discovered during the evaluation for dysphagia. The patient didn't take any medication at all. When we evaluate the patient, she also she referred dysphagia with an ECAR score of 6 points, stage 2, but also had dyspepsia and weight loss. She had lost 6 kilograms or 13 pounds in 3 months. Ancillary tests, we repeated the laboratory that in this case showed no pathological findings. Also, the ANA was negative, and the upper gastrointestinal endoscopy was normal. In 2023, the rheumatology made the diagnosis of Sjögren syndrome because of ocular and oral dryness. As the patient kept having dysphagia, we made a esophagogastroduodenal serial that showed multiple non-propulsive tertiary waves associated with delayed esophageal evacuation without a mucosal lesion. And we also did a high-resolution esophageal manometry that showed a lower esophageal sphincter with increased tone, as you can see in the images, this very red line. Absence of relaxation and abnormal motor activity of the esophageal body due to a 19% of failed swallows with palm pressurization, that is this red column you can see, in both dorsal recumbency and in supine position, and also was exacerbated with multiple swallows and the rapid swallow tests. This made the diagnosis of type 2 achalasia as the classification of Chicago 4.0. To decide the treatment of this patient, we discussed the case in a multidisciplinary committee According to the subtype of echalasia, the patient characteristics and research available in our center, we decided to make pneumatic balloon dilatation by endoscopy. And as you can see in the first picture, you have the area of the stenosis, and after the balloon dilatation, it solved. After the procedure, the patient we tried to make her drink a glass of water, and she automatically told us she solved her symptoms. At that point, she had an ECAR score of 1 point. Until now, the patient didn't repeat the symptoms. In the discussion, although the dysphagia is a very common in patients with Sjögren's syndrome, there are relatively few studies on the subject. Some studies report significant abnormalities in high-resolution manometry, other partial disorders, or fail to demonstrate a consistent motor pattern in these patients. There are reports, most of them report type 1 achalasia, that is with decreased lower esophageal sphincter pressure and reduced peristaltic velocity in the esophageal body, and the presence of tertiary waves that are totally pathological in patients with Sjögren's syndrome. Our patient presented the tertiary waves, but she presented the type 2 achalasia according to the Chicago version 4.0. In conclusion, dysphagia is a red flag symptom that requires early and comprehensive evaluation. High-resolution esophageal manometry enables the classification of achalasia into subtypes with varying therapeutic responses. The treatment of achalasia depends on its subtype, the patient's general condition, the availability of techniques in the healthcare setting, and the patient's preference. A multidisciplinary approach is always recommended. In our case, we review a multidisciplinary intra-hospital meeting, and we decided the pneumatic balloon dilatation. These are the references, and thank you for your attention. I don't know if you have any question.
Dr. Ilyas?
Yes?
What do you think about post-dilatation complications?
What do you think? Sorry?
What do you think about post-dilatation complications like bleeding, perforation, etc.?
Yes, it was something we took into account because if the patient didn't solve the symptom, we would have to make another balloon dilatation, and maybe a perforation could be a complication of it. But in this case, taking into account is a type 2 achalasia is the best option, the balloon dilatation, and it's relatively low, the risk of perforation. So that's, in this case, is the recommended option.
Nice demonstration. Any questions from audience? No question.
Okay. Thank you very much.
Our next speaker is Dr. Jason Pervez from the UK. I would like to invite Dr. Jason Pervez to present his speech on infliximab-induced seronegative hepatitis leading to acute liver failure and liver transplant, a case report. Dr. Pervez, are you there? He is joining. She's taking some longer. I think she is facing some technical issues like networking out. Welcome, Dr. Parvez.
Welcome. Thank you for welcoming me. It's just that I've been running a bit late from the work, so I wanted to do it a bit earlier. So thanks for letting me do that.
Kindly share your PPT.
Let me just see if I can.
Finally, click on share button.
Yeah, I've been doing that. Share screen. Share. Is that okay? You got
Yeah,
it?
it's working. It's working.
It's
Yeah,
working now.
you are visible now.
Okay. Right. So, as you all probably know by now, my name is Zishan Pervez. I'm one of the clinical fellow. Working in gastroenterology and also healthcare NHS trust here in the UK. Just going to go through with a case report, which is quite interesting for me, especially in the context of the fact that we do use infliximab quite a lot, and it's been in use for such a long time, and it's also a first go-to biologics when it comes to managing the inflammatory bowel disease. So it was quite interesting for me to be involved with the care of this patient. Um, do you want me to do the slideshow, or is this okay like this?
Stay next to technical team.
Right,
Yeah.
right.
Dr. Parvez, say every time next to technical team.
Okay, that's fine. So we had a 50 years old patient, a female patient who was diagnosed with ulcerative colitis and mainly presented to the hospital with the abnormal liver test. So she got referred to us as a part of the outlier referrals. So I went to see this patient. At the time of the assessment, she had very mild abdominal discomfort. She denied any change with her appetite or her weight, so those things were all stable. She was found to have jaundice, and she did give a history of dark urine for last few days. Now, in terms of her background, she received 2 doses of infliximab, so it wasn't that she's been on it for a while. So, having said that, she got diagnosed with the ulcerative colitis. Previously, we tried on few other medications and was found to be intolerant to thiopurines as well. Um, as a part of the assessment, when we discussed other potential causes, she denied any excessive alcohol consumption. There was a traveling history. She had been to Tenerife recently. There was no use of any recent steroids, no over-the-counter medications, no herbal treatment. She had any recent infection or any antibiotics used in past few weeks to months. And there was no significant family history in terms of any liver issues. On presentation, when she was seen, so in terms of her liver enzymes, her ALT was around 807. Her ELK phos was normal, and her bilirubin was around 22. Having said that, her INR was around 1.4. At that point, she was otherwise well in terms of her GCS and rest of her observations. During her stay in the hospital, she ended up getting obviously the further workup, which included imaging. So she had an ultrasound scan done to start off with, which only reported that she was found to have multiple gallstones. Apart from that, the liver parenchyma itself was not reported to have any issues, and the intrahepatic, extrahepatic ducts were all normal, as well as the portal vein flow. Following that, she had an MRCP done as well, which again, um, more or less reported the similar findings of gallstones and normal ducts. In terms of biochemical investigations, she ended up getting a non-invasive full liver screen that included looking into the viral aspects. So she had Hep A to E, which was all negative. HIV screen was negative. She had autoimmune profile, including the immunoglobulins and anti-nuclear anti-smooth muscle antibodies, and they were all reported to be normal. More importantly, she also had a paracetamol levels done in the context of her presentation, and that was reported to be normal as well. Now, while she was with us, the trend of her liver enzyme was quite significant deterioration that she had. So over the course of her stay, initially when she came in, her ALT was around 800. Later on, it progressed to almost over 1200. And Billy started to rise as well. And so she just started to develop coagulopathy as well. Later on, it was almost more than double of her ALT at the time of presentation. Billy raised up to 200, and her INR was around 2.5. And by then, at that point, she had developed encephalopathy as well. So this all was managed in a DGH. We do have liver services, but in this sort of scenario, we do liaise with the tertiary center and the liver specialist unit. And so they were contacted. In view of this deterioration, this patient was transferred across to them. And based on all these other investigations that they were negative, she ended up getting a liver biopsy. Now, the liver biopsy report, the histology report, was uh, was reported as changes suggestive of acute lobular hepatitis and necrosis or bleeding necrosis. So, as there was no other evidence of chronic liver disease, and as we all know, the overlap and the association with the PSC in terms of background of having IBD, and particularly ulcerative colitis, the features suggestive of PSC were also looked into, and those were all reported as negative. So this histology confirmed changes which were suggestive of seronegative hepatitis, and in the context of no other definite trigger or the source infliximab was thought to be the leading cause here to ending up causing liver injury. So this was the slide again. As you can see, the change is suggestive of parenchymal necrosis, and probably there were no presence of any chronic liver disease on the findings. So at the tertiary care center where she was transferred to, where she had the biopsy done, she deteriorated over this period of four weeks or so, and she ended up getting liver transplant. Following the liver transplant, she was being managed by the transplant unit. She's currently doing quite well without any gastrointestinal or any hepatic symptoms. She's been on immunosuppressive medications, called mycophenolate and orteza. She's also being followed up by the IBD team in our center, and she had a colonoscopy done after all this, and it showed stable kind of presentation, nothing to be of concern, and her symptoms have been stable as well. A bit about TNF inhibitors. They're not well known to have any significant liver-related issues. However, there are few cases which have been reported, and they state otherwise. The way it can affect, it's still debatable. There's still quite a lot of work that needs to be done. The exact mechanism is not fully understood at this point, but it can affect direct and indirect liver injury, which can even lead to seronegative hepatitis. Occasionally, in some cases, it would resemble autoimmune hepatitis in terms of clinical, biochemical, and even histological aspects. In other cases, these markers would be negative, and despite of it being the immune-driven infliximab-induced liver injury, there are cases where it would lack the typical presentation of autoantibodies, and it can be negative in those cases. As in most instances, there are are positive outcomes. However, in rare occurrences, it can lead to acute liver failure, and there have been few cases reported about that. In those cases, it necessitates that the patient are urgently managed and transferred to the transplantation unit. And that this case basically highlights the importance of that as well, and being a bit more vigilant in terms of monitoring of these patients, because as I said, it is quite common biologic that we use in terms of IBD management. So as I said, that it is uncommon, but a serious complication of infliximab. And infliximab, following the start of infliximab around 1998, or following the approval, around 2004, there were a few cases which were reported, and the reports were being published that it is connected to side effects or complications that are associated with the liver. So timely recognition, hepatic decompensation, and all those factors should be taken into account. Um, in the context of presentation and the background can be a bit challenging. As I mentioned earlier, the association with PSC, sometimes having a typical presentation with defining suggestive or as being seen in autoimmune hepatitis. Other cases you would see them not being present. So there's sort of an overlap as well. So determining the correct or exact etiology when someone presents with the elevated liver enzymes, it can be a bit challenging. And as we all know, that autoimmune hepatitis is associated with raised immunoglobulin antibodies. There are approximately 20% of patients with features of AIH who would lack those things. So that can make it a bit tricky. It is hypothesized that in certain individuals who have no history of liver disease, they can still end up developing the liver-related injury in the context of infliximab. And the two theories behind that is that either these individuals have got any genetic susceptibility, or there is a sort of an immune complex formation due to selective activity of T helper cells or cytokine blockade that lead to this activity and ending up causing the liver injury. The main stay of treatment in these cases would be steroid therapy, possible transplantation in the rare cases. Patient must avoid anti-TNF therapy for life. We've been through these details, so I'm not going to repeat this slide in terms of summary. So a few of the things that I would like to reiterate again, although as we established that it's a rare event, but it's important to take into account, and one of the most, and it must be taken into consideration at the time of initiation of the therapy. These patients should be monitored, and if at any point there is concern raised in terms of the, liver enzymes being abnormal, extensive workup needs to be done to further evaluate. The mechanism of action likely involves development of autoimmune hepatitis, can be seronegative, as in this case. Generally, again, you would see a typical features of lab findings, histological architecture, but those things can be negative as well. The mainstay of treatment is steroid. If that fails, or critical deterioration of the patient leading to acute liver failure, with coagulopathy and all those the other factors that are taken into consideration, can lead to liver transplant. Patient must avoid anti-TNF therapy for life in order to prevent the recurrence of ALF. There are few reports which have been published in terms of the alternative medicine, what we're going to do in patients, especially who ended up getting a liver transplant and have got a background of IBD. Interleukin 12, the 23 biologics, as well as the integrin antagonist, namely ustekinumab and vedolizumab, have been reported to be a safe alternative. And there have been a case report where Mr. Kinemab was reported to have a better outcome in these patients as compared to the Lido. But they both are considered to be the safe options to be used as an alternative. And definitely further studies are needed to recertify these patients who have got inflammatory bowel disease to restratify them in the context of developing acute liver failure. These are my references. Thank you so much.
Thank you, Dr. Pervez. Nice talk. Any questions from audience?
Hi, Dr. Paresh. This is Dr. Mathur from William Harvey. My question is, what was the duration of last infliximab given to the and in the starting of ALF? Is it an index episode, or is it? I think patient received couple of doses and then
Yeah, so the patient received the second loading dose.
okay. So
Yeah.
it's just in the induction phase, you mean? Okay, that's fine.
Yes. So she wasn't
Okay.
on the maintenance therapy. She received the two doses, the loading dose, and following the second loading dose, she wished to
Yeah.
go on a holiday. So this
Okay.
all happened during while she was there, and when she returned back, he had
Yeah.
obviously the blood workup done prior to her third dose, and that's
Yeah.
when it was picked up, and then the one thing led to another.
Okay. And is this the IBD is having any family history, or is a so
No, interestingly, there is no family history of any liver
okay.
condition as well as IBD. So it was, yeah.
Mm.
And it is becoming quite, you know, quite evident now that the spectrum of IBD is changing here. I mean, in the Western countries and especially in the UK. Before we
Yeah.
used to see a lot in the Caucasian population, but
Yeah.
now, the spectrum has changed, and obviously, there's
Yeah.
various factors, but
I do
irrespective
agree
of,
with that.
yeah, yeah.
I have like we have like 800 patients on infliximab and
Hmm.
adalimumab, and
Yeah,
I'm feeling that this infliximab somehow is not working well actually nowadays. But anyways, we will do that an audit and we will see it from there. Yeah,
yeah. Thank you. Good
good,
luck with that. Thank you.
good. Thank you.
Okay.
Thank you, Dr. Pervez.
Thank you.
Next talk. Now we will take a lunch break for one an hour. We will rejoin after 1 hour. Thank you.
Hear you. Hello.
Hello, ma'am. A very good afternoon, everyone, and welcome back for the post-lunch sessions. I'm Dr. Garima Anandani from India. I'm working at the All India Institute of Medical Sciences here in India. It's my pleasure to have you all at this wonderful event hosted by UCG Conferences. We'll continue further with our post-lunch sessions. I would like to invite our next speaker, Ms. Rania Mohammed Othman from Syria, to deliver a talk on dental implants in the vicinity of OSCC possible. Please, ma'am. Ma'am, please unmute yourself. Ma'am, can you please unmute yourself?
Good morning. Oh, can you hear me?
Yes, ma'am. Now you're audible. Yes, ma'am. Now you're audible. Ma'am, are you there?
Hello. Can you hear me now?
Yes, ma'am. Now you're audible. Yes, ma'am. Then there is some network issue on your side, I feel. Ma'am, can you please check the internet on your side?
Okay. But I have a problem. My presentation.
I think ma'am is having some network issues on her side.
Yes, I'm here.
Yeah, ma'am, I can hear you now.
Okay.
Can you share your screen?
Okay. Now yes. Okay. I tried to share. Is it good now?
Yes, ma'am.
Is it
Yes,
good?
ma'am. You're audible now. Yeah. And you're visible too. Yes, ma'am.
Yeah. Okay. Today I would like to.
Ma'am, our team will share your PPT.
Is my presentation is my presentation?
Yes,
Can you
yes,
see my presentation?
yes, ma'am. You'll have to say next page whenever you want to change the slide. Miss Rania, are you there? Ma'am?
Yes, I'm I'm here, but I can't. Yes, I would like to with the and flower. I can't. Next slide. The next slide, please. Draw my presentation from here. No. The first one. The first one. Yes, yes, I would like to welcome you from from Damascus with the flower. It's not any flower. It's Damascus jasmine. I hope peace to my country, Syria, and all and to other countries. Yes, the next slide, please. This is Damascus jasmine. I like it. Okay, the next one. Today, first of all, if a patient come to your clinic and ask you about treatment with implant, usually you asked him about his medical history, and if he told you that he had an oral cancer or an previous cancer, here often you will feel some trouble. So today we will talk about correlation between squamous cell carcinoma and implant and treatment with implant. First of all, oral squamous cell carcinoma, as we know, is the most common cancer, which represent about 90% of all cancers, and it may often affected men between 50 to 60 years. Okay, the next one. Next one, please. The main risk factors of oral squamous cell carcinoma, as we know, is tobacco and alcohol use, but now there's some changing in this risk factors as being under the age of 40, and maybe see carcinoma in women who had not processed any risk factors, and development from potential malignant lesions. Nowadays, the next, please. Nowadays, there is other less typical risk factors as nutrition and radiation exposure, immunosuppressants, chronic inflammation, and human papillomavirus infection. Okay, the next, please. As we know, dental implant nowadays is the first topic for treatment in a case of oral rehabilitation, and the success rate of dental implant about 94.6%. The next, please. When number of installed implants increase, so the next, please. The next oral squamous cell carcinoma in relation to implant also will rise. And the next. As we know, soft tissue and supporting structure around implant, around dental implant, will expose to oral cavity flora and bacteria. So it may undergo some pathologic changes. The most common lesions around implant is inflammatory lesions or inflammatory nature lesions, which is triggered by the accumulation of bacterial biofilm. So we classified, peri-implant lesions are classified as peri-implant mucositis, which is confirmed to soft tissue as gingiva and maybe periodontal ligament, and peri-implantitis, which characterized by loss of supporting bone. Okay, the next one. But the most common lesions are peri-implantitis, as we say, which is triggered by bacterial origin. The next one, please. But nowadays, malignant lesions have been described, and these malignant lesions will affect the prognosis of implant rehabilitation and the life of the patient. The most malignant lesions is in the vicinity of dental implant are the squamous cell carcinoma, but there are some rare cases about breast cancer or lung cancer or sarcoma and even plasmacytoma. The next one, please. The problem, what is the problem here? Because the high incidence of peri-implant inflammatory disease, some dental professionals or some practice treated these lesions, but does not or don't send the specimens to the microscopical analysis. This means they don't have a biopsy and examine it by histopathological analysis, and the study showed that 3.6% of these lesions were malignant lesions, mainly squamous cell carcinoma. Okay, the next, please. This percent, 1.5% of oral cancer cases, this is the peri-implant malignancies. It's not low. It's not low percentage. So we must to take care to be careful when we treat it with these lesions. Okay, the next one. peri-implant disease and cancer, the correlation between it. As we know, oral cancer usually appear as hypertrophy masses, as exophatic masses, or as an erythema lesions, which appear as red lesions, or as an ulcerative lesions. Ulcerative lesions, here I will remember you that this ulceration will be painless and it's not healing. By the way, inflammatory peri-implant disease also, as we say, calcified as pre-implantitis and peri-implant mucositis. But peri-implant disease and oral cancer has the same epidemiologic pattern and risk factors, which is the age of patient is more than 60 and often have tobacco and alcohol use. Okay, the next one. As I said, the risk factors between dental implant and oral squamous cell carcinoma is similar. About the dental implant, we said about tobacco smoking, as we said, and the study appears that more smokers have post-operative infection and bone loss than non-smokers. When we talk about oral SSA, we say the most important risk factors, as we say, alcohol use and smoking. The next one. 34.98% of patients diagnosed with squamous cell carcinoma around implant were smoker and drinker. Okay, the next one. Here we will talk about some studies about this topic. In a study of 111 biopsies of peri-implant lesions, this study showed that 30.6% of those had histopathological diagnosis of oral squamous cell carcinoma, and this study was, I think, in 2021. And another study, there was 2.9% of 68 dental implant-related lesions were also oral squamous cell carcinoma. The next one. Okay, the next one. The first cases of malignant lesions around implant were published at 2001. It was about this case report described a patient with the long-standing histology of leukoplakia and verrucous cell carcinoma. The next one. In a study of 47 cases of oral malignancy involving dental implant were published between 2000 and 2016. It was literature review to 25 articles. The result was female affected more than male in this study, with the ratio of 1 to 1.5. Most of patients was of age 67.2, and the mandible was affected more than maxilla. Most cases was or most lesions were 85.1 SSA. The last one were metastases from other organ, but 54.76% of all cases of squamous cell carcinoma around dental implant arose in patients with history of cancer. There's the risk factors, the high risk factors. Some of these tumors were oral squamous cell carcinoma from lung, from intestine, from thyroid, and from breast cancer. So the next one, please. The possible contributing, oh, step by step, please. Okay. Possible contributing factor of relevant peri-implant oral malignancy were, first of all, the first theory was dental implant corrosion and possible association between this corrosion product and SSA. The second one was a possible association between particulate titanium and SSA. Some study describe an increase in the incidence rate of hematological tumor and lymphoma with the increase of corrosion. And the third one is migration of malignant cell through the implant surrounding sulcus. Here we have two options. There is no reason to believe that the space surrounding an implant is biologically different and would favor a tumor invasion. And another options that an undiagnosed malignant or pre-malignant agent in the area of previous to the placement of implant was present, and that the implant simply carried the tumor into this bone. The last one, carcinogenic effect of substance metallic ions released after implant placement. Okay, the next one, please. Of course, radiotherapy. This figure will show us the chemical corrosion surface wear and how this icon or how this particulate will trigger the inflammatory reaction and will affect or will result to bone resorption. Okay, the next one, please. Okay, step by step is here. Here we have the possible association between corrosion products release and SSA. A commercial pure titanium causing galvanic gurate. A corrosion implant depressed could result in inflammation, and inflammation will lead to implant persistence and bony resorption. So from these three hypotheses, we can accept and failed implant, which may in cases of peri-implantitis, and this will affect the carcinogenicity of the metal ions. This depends to the patient, depending on three factors. The surface area of the implant and the number of implants.
Ma'am, can you please use the internet on your side?
To multiple. Okay, I can't hear you.
Yes, ma'am. Yes, ma'am. Now it's fine.
Okay. Can I continue?
Yes, ma'am. Please continue.
Implant oral malignancy with implants were also. Okay, the next one. The next one, please. So implant can cause a state of chronic inflammation in two kinds of patients. Maybe patient with risk factors or with the previous history of cancer, and that is that this may be associated with the appearance or recurrence of oral. There is a debate regarding whether malignant changing occur in peri-implantitis or if the manifestation of peri-implant oral malignancy present signs similar to peri-implantitis. The next one. Okay, the next one, please. So the question arises regarding whether the extent of dental implant possesses risk for malignancy. Peri-implantitis is characterized usually by prolonged inflammation, and this inflammation, this affected or this inflammation associated usually with malignant transformation in cancer. If inflammation persists, this induces cellular proliferation and prolonged cellular survival, and this will activating the suppressor. Okay, the next one. So this genetic instability and great risk factors. In these figures, we can see the potential mechanism of oral cancer. Here we can see the risk factors to remember it: tobacco, alcohol, and titanium corrosion. How to affected by bacterial biofilm, by inflammation, by oral pH and acid food. This will affect the membrane of the cells, icons. This may cause chromosome alteration and in the DNA, which will result in DNA damage. This will increase carcinoma will develop in. Okay, the next one, please. The next one. The most common were peri-implantitis, swelling in the gingiva and redness in the gingiva and around the implant. No, the last one. And maybe appear as an exophatic masses without ulceration. Will early defined spawn around implant. Okay, the next one. Features. Yes, can the next one, please. In histological features, between the neoplastic cells, we can see neoplastic cells. The next one, please. This is a case about a 64 years old woman. She has an exophatic ulcer covered by necrotic tissue. And in the radiographic view, we can see ill-defined bone root we can see which is characterized by atypical prominent nuclei. We can see mitosis. We can see
Ma'am, you are not audible.
Okay, I'm available now.
Yeah, yes, ma'am. Yes.
Environmental situation here in Syria is somewhat. Okay, next one, please. Can you hear me now?
Yes, ma'am. Ma'am, please continue.
Okay, I can control this. Next one. Okay, another case about male of 62 years old. The lesions appear as erythematous. And we can see here an ulcer and swelling. In histopathological view, we can see neoplastic cells here and keratin pairs. These cells appears as dysplastic cells, which pleomorphism, and these cases was well differentiated cell carcinoma. Okay, the next one. Okay, the next one, please. Oh my God. Another cases appears as exophatic gingiva. Here we can see in the radiographic, we can see loose bone here, ill-defined loose bone, and in histological view, we can see a neoplastic which characterize the lymphoma syndrome. Next one, please. Next one, please. Infiltrative ulceration, we can see here, and in panoramic, we can see the bone loads here near the canal. Okay, next one. This is view, we can see cells, undifferentiated cells, which characterize the squamous cell carcinoma. And here we can see another case of malignancy around implant. Here, sample of the row and part of the skin. Okay, next one. No, 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 no. Here I would this you okay, this one part, please. Remind these tips very well. Number one, it's essential to perform a delicate oral cavity examination before implanted treatment. This is very important thing. We have to examine all the oral cavity or only the tooth. There is no established association between the occurrence of dental implants and oral squamous cell carcinoma. There is no evidence to corroborate that the bone implant interference is a preferred route for tumor invasion. The next one, the incidence of trauma next to the treatment. So here we can be very careful when examine a patient with the previous oral cancer. For this infection. Okay, the next. Okay, the next one. Peri-implantitis must be assumed casually in patient who has a previous of cancer, and malignancy should be suspected when the peri-implantitis lesions does not present as a classical features and does not respond to treatment, particularly in patient has risk factors for oral cancer. And in these cases, we will be very careful to examine this patient, and the histological exam by biopsy, excisional or incisional biopsy of every lesions around dental implant, surgical removal. This is the most important things. Every peri-implantitis does not treat it and have unclassical features. We have to take a biopsy from these lesions and examine it by histopathological analysis. Peri-implant oral malignancy occur in the form of peri-implantitis, so to be different between these two lesions, and this accepting exophatic masses with or without ulceration, to be remembered. Dental implant favor malignant transformation of pre-malignant lesions is unknown now. Further studying the okay, a regular check-up of the peri as when we work as a team. Okay, the next one. As a team, together, everyone achieve more. We have always to work as a team, and all of us will be achieve more. Thank you for your listening, and I am very pleased and I'm very happy to join this conference. Thank you.
Thank you, ma'am, for the wonderful talk. I would like to ask an audience if anyone has any question. It seems there is no question, ma'am. Thank you for the wonderful talk. Thank you, ma'am. Please. Now I would like to invite our next speaker, Dr. Banking Fu from China, to deliver the talk on survival analysis using multimodal data from digital pathology images and genomics based on mutual information optimization. Please, sir.
Yes. Yes. Hello, everyone. I'm honored to attend the conference. First of all, let me introduce myself. My name is Fu Bankang, and I'm from Guizhou University and the Guizhou Provincial People's Hospital. The topic I will share today is the survival analysis using multimodal data from digital pathology images and genomics based on mutual information optimization. Today's speech will mainly focus on the following four aspects. And the first part is the research background. According to the Global Cancer Statistic Report, in 2020, there were 19.29 million new cases of cancer worldwide, and 9.96 million cancer deaths worldwide. There were 4.57 million new cases of cancer in China, and 3 million deaths. This shows that cancer brings a huge burden to families and society. Taking gastric cancer as an example, it is crucial for clinicians to accurately assess the prognosis and beneficial choice of GC patients. Since its development, the AGCC-TM staging system has been widely used in tumor prognosis assessment and guiding the selection of treatment options. However, with the advancement of medical technology, we realize that this staging system inevitably has limitations. Patients may have different results in the same TM stage, while patients in different TM stages may have similar results. This means that the existing prognostic evolution can't accurately explains the complex biological manifestations of tumors. With the advancement of technology, more and more modern data have emerged, such as sequencing data. How to use multimodal data for individual patient analysis is a huge challenge. The current hot development of artificial intelligence technology has also been integrated into all aspects of life. Common ones include natural language processing and computer vision. AI methods have also made greater progress in protein prediction. In addition, experts related to artificial intelligence technology has won the Nobel Prize. This undoubtedly shows the huge impact of AI technology on life. AI technology has been applied to the analysis and the processing of medical data, such as in the classification of pathological images, organ segmentation of in-situ images, and the image restriction for the brain. In addition, a multimodal human pathology AI assistant has recently been trained using multimodal data, including image data such as WSIs and text data, case reports, which can be used to communicate with it like chatting with ChatGPT. The medical data currently includes a lot of multimodal data, such as radiological images, pathological images, diagnostic reports, genetic data. This multimodal data describe information of different dimensions. From the image on the right, we can see the information of different mathematics also contain information of different scales. And the second part is related works. The first is the Chen's team proposed a multimodal coalition transformer for survival prediction in gigapixel whole slide images. This study used pathological images and genetic data as input, guided pathological features through genetic features to achieve multimodal feature interaction, and ultimately achieved the purpose of prediction. The next is Justin proposed the cross-model translation and alignment for survival analysis. This work is also based on pathological images and geomic data. It first undergoes feature encoding of different modalities, then uses the cross-model attention model for multimodal data interaction, and finally performs survival analysis through model alignment and multimodal fusion. The next is the Jones team proposed modeling dense multimodal interactions between biological pathways and histology for survival prediction. This method uses different pathways to group and embed transcriptomics data. The pathological images are first grouped into patches, and then feature characters are used for feature encoding. Finally, risk stratification is performed through different methods of cross-attention. And the third part is the research method. We neutralized paired genomic and whole slide image data from stomach adenocarcinoma, SGAD, and lung adenocarcinoma, LUAD, in the TCGAD site. The genomic data used in this study include RNA sequencing, copy number variation, and DNA methylation, which shows the basic information of two data sites in TCGA, including age distribution, ethnicity statistics, and the survival follow-up time. The age of SGAD and LUAD data sites is mostly between 50 and 80 years old. The most common ethnicity in the two data sites is white. We also saw the follow-up distribution of survival results. And artificial intelligence can be roughly divided into two categories: traditional machine learning and deep learning. The key difference is that the former relies on handcrafted features such as color and texture, while the latter uses features automatically extracted by convolution neural networks, which involves the detection of information that is difficult for humans to obtain. For example, when developing deep learning models for automatic Gleason grading, AI learns from annotations provided by pathologists. Different training strategies require different levels of annotation information. Supervised learning requires pathologists to manually draw each ground on whole slice images and provide Gleason pattern information, which is very time consuming. And the next, weekly supervised learning typically uses slides or patient-level Gleason scores recorded in pathology reports and inputs without additional annotations. In addition, semi-supervised learning leverages a small set of precisely labeled data and a larger and labeled this site to improve performance. This different learning style give us options for processing pathology images. And multi-information refers to the degree of correlation between two random variables. After determining the value of random variable x, the degree of weakening of the uncertainty of another random variable y. So the minimum value of mutual information is 0, which means that a given random variable has no relationship with determining another random variable. And the maximum value is the entropy of the random variable, which means that a given random variable can implement the uncertainty of another random variable. This concept is relative to conditional entropy. The formula expresses the relationship between mutual information, condition entropy, and joint entropy. KL divergence is called for the information gain obtained if Q is used instead of P. For the sake of analogy with the information zero, it is also called the relative entropy of P with respect to Q. From the formula, we can see the relationship between multi-information and KL degree divergence. And this is a variational encoder. V is a generative model that models the probability distribution of input data X through latent variables Z. The first defines the data generation process. The V assumes that the data is generated through a latent variable Z, and the goal is to estimate the Magen likelihood P theta X. And the second, compute the impedance lower bound. Since directly computing calculating P theta X is typically intractable, variation inference introduces an approximate posterior distribution Q phi Z given X. And the third parameter, the variational posterior Q phi Z given X. The approximate posterior Q phi Z given X is parameterized by an encoder network and is assumed to follow a Gauss distribution. And fourth, simple latent variable Z to address the challenge of backpropagating through a sampling operation. The reparameterization trick is applied. The 5 decode to generate data. The decoder P theta X given Z reconstructs the input X from the latent variable Z, assuming P theta X given Z is a Gaussian training objective. The model parameter theta and phi are optimism to maximize the album. And the next, referring to previous work, we processed the genomic data as tubular data and use it as input, using self-normalizing neural networks to encode genomic features and finally obtain gene features. And for the processing of pathological data, the original input is the WSI. First, the background area is removed using an automated program at 40 times, and then the color normalization method is used. After that, the image is cropped into non-overlapping patches of size 512 by 512. For these patches, the red light is used to extract features, and then the transformer is used to aggregate global features to finally obtain the feature representation of the pathological image. And this page is the process of multimodal joint molding. First, the variation autoencoder is a latent variable model that can perform scalable unsupervised representation learning, as shown in Formula 1. For example, model data, VE defines the magnitude log-likelihood through a latent variable z. Since it is usually not feasible to directly calculate log p set x, as shown in Formula 2, VE maximize the computable impedance lower bound, namely elbow. For the prognostic decoding task, VE is conditioned to multimodal inputs, including pathological image features and corresponding geomic features. Forming a multimodal VE is joint magnitude log-likelihood, and the multimodal variational elbow can be formally expressed as Formula 3. We choose mixture of products of experts for the prognostic decoding task because it has powerful joint latent representation learning capabilities and cross-model generation capabilities. The optimism objective can be further written at Formula 4. And this page mainly describes the process of maximizing intra-model multi-information. We first introduce intra-model multi-information regularization into the original elbow objective, which prefers high multi-information between joint latent variables Z and the single modality XM. The definition of MI between joint latent variables Z and the observations XM in the posterior distribution is shown in Formula 1. We derive an accurate and direct variational lower bound of MI as shown in Formula 2. To simplify the complex of the inner layer calculation expression, we apply lemma 3.1 in InfoGAN and rewrite the formula as the Formula 3. Finally, we define the intramodel multi-information maximization regularization term our intro of multimodal VE as shown in Formula 4. And the above intro modality multi-information regularization aims to elevate the problem of learning consistent and useful joint representations in multimodal VEs. However, due to modality-specific random noise and portional overfitting problems, The joint generation of all modalities can be guaranteed to be strongly constant. Therefore, we introduce point-to-point mutual information regulation our inter to improve the mutual information between multiple modalities. This can surprise task irrelevant, modality specific noise and keep the generation constant as much as possible. Our inter is defined as shown in Formula 1. The motor information can be calculated by the logarithmic ratio of the probability, as shown in Formula 2. Formally, we combine the joint optimization objective with the proposed two mutual information regularization term our inter and our inter to form the overall objective function. And the fourth part is results analysis and summary. The C-index, also known as the concordance index, is a metric used to evaluate the performance of survival analysis models. It measures the ability of a model to correctly order pairs of individuals in terms of their predicted survival times. The results show that compared with other methods such as SNN-CMTA surpass, our proposed model has the highest C-index scores on the RTAD and LUAD datasets, which are 0.67 and 0.61 respectively. We divide the patient cohorts into high-risk and low-risk groups according to the survival time predicted by the model. We performed a logarithmic test to evaluate the difference between the high-risk and low-risk groups, and the p-value was less than 0.05. The experimental results demonstrate significant differences between the high-risk and the low-risk groups across both datasets, underscoring the model's ability to effectively stratify patients based on several risks. Finally, let's summarize our contributions and the future work. Our research mainly focuses on the challenge of not being able to effectively integrate data from different modalities of genes and pathology. For survival analysis, we proposed a multimodal survival analysis framework based on mutual information optimization and achieved good performance on two cancer datasets. In the future, we would like to expand our work to other cancer types to obtain more extensive validation. In addition, our next step will be to incorporate data from other modalities to obtain a more comprehensive survival analysis, and we will perform more experiments to obtain more clinical validations. That's all. Thanks for your listening.
Thank you, sir, for the insightful presentation. Thank you so much. I would like to ask from the audience if any questions are there. The house is open. Any questions? There are no questions, it seems. Thank you so much, sir, for the wonderful talk. Now we'll proceed with our next speaker. I would like to invite Dr. Abdelwahab Deimat from Algeria to deliver a speech on a novel multiomics analysis reveals dose-dependent and temporal changes in regulatory pathways induced by natural compounds in breast cancer cells. Please, sir.
Bismillah ar-Rahman ar-Rahim. Hello everyone. Can I share my screen now?
Yes, sir.
Okay, yeah.
It's
Okay, I'm sharing my screen. Okay. Is my screen already shared? No, ma'am?
Yeah, it's visible, sir. You can proceed.
Okay. Okay. So, Bismillah ar-Rahman ar-Rahim. Hello everyone. My name is Abdelwahab Deimat, faculty lecturer in University of Sila here in Algeria. So, I am PhD on biotechnology and bioengineer. So I have plans to share our study about novel multi-omic analysis reveals dose dependent and temporary change in regulatory pathways induced by natural compounds in breast cancer cells. So we follow this table of content. We start by highlight and objectives, showing the workflow of study and presenting some results because our study in progress and in process to be published in few days, few weeks next. So we try to make just a short presentation of the result and make a discussion. We finish, of course, with conclusion and some limitation. So our integrative mixed data analysis methods have the potential to investigate the complex change underlying stereochemical exposure responses. So we've tried to provide a comprehensive analytical method applicable to future research, exploring mechanism to toxicity when more time and those exploring omics data are available. So this may promote the generation of models simulating the relation between toxin and advanced outcome pathways called AOP accurately. So we try to develop reproducible protocols to support the integration of multivariate multi-omics data to facilitate the incorporation of omics techniques into chemical risk assessment. So in our study, we try to present the analysis for the first time for integrating multi-omics data to concurrently capture dose-dependent variance and temporal change in response to chemical exposure. The analysis combines statistical analysis, machine learning, and bioinformatic analysis methods. So what we are looking for as a result from this work, first of all, touch decomposition of omics data variance over time and intensity chemical stimuli together provides a more profound understanding of complex cellular regulatory mechanisms by capturing molecular events sequence, which provides an important mechanistic insight into toxicity and benefits the development of universal modeling of cellular response under different experimental conditions. Second point, instead to analyze each layer separately, omic data separately, we try to combine the result at the end. So we try to propose an integrative analysis method to investigate transcriptomics, proteomics, and phosphoproteomics. This is the workflow of study. So we treat our cells with our natural products, different concentration in different time manner exposition. So after that, we try to collect the transcriptomics, proteomics, and phosphoproteomics. So the second point, we try to apply machine learning models like the FPSCA and metabolic factor analysis, and we do some statistical analysis. After that, we try to post-analysis trying to apply for bioinformatic tools for the transcriptomics and proteomics, and also for the phosphoproteomics for the pathways analysis, the PPI network, and the kinase activity inference. So, as we said, we use the experimental data from the natural products, including transcriptomic, proteomic, phosphoproteomic, in case to implement the analysis. So we present in-depth integrative analysis of transcriptomy, the multi-omics and site-specific for the phosphoproteomics. So the data sets measure the serial response to different doses of natural products of three time points we were collected from the literature from our previous paper and research. So the PCA here, the principal component analysis, we try to confirm the serial response varies with the time and concentration. The multi-omic factor analysis, we try to identify six response pattern. For the analysis for the rectum, GCI, strains, and the TCA to reconstruct the serial event. After that, we try to apply machine learning method to include PCI, as I said, and the multi-omic factor analysis, and the visualization of PCA. So we are it enables for preliminary observation about whether the omics data change with variables, time and dose. So the MOPA was employed to infer the latent factor that capture variability. Biomolecules here associated with the latent factor in each layer omics were identified and further analyzed for biological function. So for the last point here about the bioinformatics analysis methods, so we try to include reactome GCA sub platforms here to integrate transcriptomics and proteins data for pathway analysis. For the string database here to construct PPI protein-protein interaction network for phosphoproteomic and kinase substrate enrichment analysis called KCEA. So to infer kinase activity. Here's some results about our sensibility, our treatment of our natural products against MCF cells, breast cancer cells. So in time and dose manner. Sorry. Yeah, comparing to the paclitaxel as this positive testimony. Yeah. So. For the discussion here, the use of omics techniques in understanding toxic mechanism has seen a significant increase in recent studies. So focusing primary temperatures on our dose-dependent responses in our study and in our future paper in online start of 2025. So this study either centered on a single source of variation or analyzed states independently for each expected condition. So our research on this innovative multi-omics data analysis. This amalgamates statistical analysis, machine learning techniques, and bioinformatics tools. So we utilize a publicly accessible data set of serial response to natural product compound. So to demonstrate that our analysis can discern temporal and dose-dependent variance pattern from heterogeneous data, reconstruct an underlying cellular response network, and encompassing pathway analysis, PPI network, and kinase activity inference. Ensure the PCA visualization unveiled trend patterns in three omic data sets correlating with the natural concentration and the passage of time. This pattern indicates distinct biological process under different natural product consideration at various time points. Subsequent differential expression analysis uncovered the proteomic response after 4 hours time point. And given the central dogma of molecular biology with the proteomic being downstream of transcriptomic and protein translation and synthesis takes hours, the observed short-term adaptation may be linked to post-translation modifications such as phosphorylation in very early cell signaling events and ubiquitination in cell cycle control. We also noticed that the number of biomolecules changed in the proteomic and phosphoproteomic did not allow increase proportionally with the concentration, suggesting complex cellular response regulatory mechanism. Thereafter, multi-group multi-omic factor analysis identified the primary source of variance across time and dose in the three omics data set, revealing 6 factors with time and dose dependence. The result also demonstrated that on the 10-minute time point, a variety of protein underwent regulation in cell exposed to low concentration of natural products exposure. So analysis of the reaction GCA pathway revealed the regulation of several signal transduction pathways, including those controlled by HADHOG and WNT, RO GTPase and Myro GTPase and RO BT B3 and NAPK family, along with the adaptive immune system and cell cycle. For the PPI, the protein-protein interaction network and kinase activity analysis confirmed that the PAK family regulated cell motility and morphology by concentration of RO-GTPase and cytoskeleton reorganization and nuclear signaling. As the concentration increased to 10 micromolar, signaled by the AGF1R insulin receptor, PDGF and VEGF were regulated. Further, PPA network and kinase activity analysis validated the cellular process such as cell cycle eukaryotic translation, mitotic promethephase, axon guidance, and RNA processing experienced in this regulation. At the fourth point, after the fourth hour points, the regulation theory of the pathways as metabolism of steroid, vitamins, and cofactors aspect of membrane trafficking, RNA metabolism as simulation increasing with concentration. At the 24-hour time point, pathways regulated at low caffeine concentration here as a standard comparison. At the 4 hour points were also regulated across all concentration. So as the concentration increased, the extent of which pathways, such as metabolic process, particularly steroid, nucleotide, and inositol phosphate metabolism, signaled by GPCR, the neuron system, and aquaporin-mediated transport increased. The PPI network and kinase activity inference and identify that cellular processes such as cell control, apoptosis, circadian rhythms, protein synthesis, cell growth, and cell proliferation also underwent regulation. To conclude here, in summary and to sum up, just here our integrated data analysis method have the potential to investigate the complex change underlying cellular chemical exposure response, which provides a comprehensive analytic method applicable to future research exploring the mechanism of toxicity when more time and those exploring omics data are available also, of course. And ultimately, this may promote the generation of models simulating the relationship between toxin and IOPS. Our study have some limitation here. So even if the analysis provides an important protocol for applying omic techniques to derive insights into toxicity mechanism, which present limitations such as bioinformatic tools yield extensive information from each factor, necessitating a robust knowledge reserve and substantial processing time to extract key data, indicating the need for an efficient bioinformatic result handling tool. An efficient tool that can handle bioinformatic results is needed. Furthermore, the application of MPS natural products data include only 3 time points. So only the transcriptomics was recorded at 24 hours, which makes the dynamic kinetic results sparse. So this may lead to the loss of some key information about the intermediate time points. I would like to present our drug discovery and IAML expertise as collaboration and research service. Please visit this platform and be in touch with us. Thank you so much for this opportunity to show our study, our services, and I'm so pleased. I'm so thankful for the ECG committee for this great opportunity to show our talk. Thank you so much, and you have talked about.
Thank you, sir, for the informative and lucid presentation. The house is open for any questions from the audience. If anyone wants to ask anything. No questions, it seems. Thank you, sir. So we'll proceed further. Yeah. I'll welcome next poster presenter, Mrs. Heather Debru from USA. She will deliver the speech on tissue processing of fresh patient normal tumor specimen Using the Apredia reverse tissue processor results in excellent morphology and isolation of high purity nucleic acids. Please, ma'am.
Thank you very much. I appreciate that. I'm going to go ahead and share my screen now, if I may.
Yeah, sure, ma'am.
Excellent. Can you see the screen okay?
Yes, ma'am. It's visible now.
Okay, very good. Thank you. Again, my name is Heather Breed. I am the Director of Tissue Processing for Apredia. I am located out of Chicago, Illinois. So good afternoon to everyone. It's very early in my morning. I appreciate the time to present today. What I intend to present is going to be a brief data set of the comprehensive study that we have been performing on the Revos rotational tissue processor. And just to note that the study as it stands is phase 1 of the study. And so I'm very excited to present to you today. As mentioned, what I plan to introduce to you is phase 1 of a tissue processing study utilizing fresh patient and normal and tumor specimens processed on the Revos tissue processor with the overall goal to look at the overall concentration and quality of the nucleic acids and also touching upon just briefly with the morphology. The study that I'm presenting today can be found on the Apredia website. My information can be found below. And so I'm very excited just again to provide you with a brief overview. This will not be comprehensive to all the data, as you can see. There's quite a bit, but just wanted to provide some of the highlights. And I look forward to speaking to any of you if you have any additional questions. So really the objective for the study that we performed is really to understand as it relates to our customers and our customers' patients is the overall understanding of the downstream effects that tissue processing has on next generation sequencing, single-use testing, and really our ability to provide the best-in-class isolation of high purity nucleic acids. So really for many of our customers and for I'm sure many of the anatomic pathology departments on the call today, nucleic next generation testing is being brought in-house to many of our customers, and it brings its own set of challenges. So we really wanted to help understand and have a higher focus on the nucleic acids and the not only the purity of them, but the ability to provide high enough concentrations to be able to take the patient tissue, typically tumor tissue, and perform next generation sequencing on that tissue. Essentially, this provides us with an understanding so that we can share with our customers and the pathologist of successful abilities to do next generation sequencing in-house in their anatomic pathology laboratories. So if we look here, again, as mentioned, just wanted to provide just different data points of the poster that can be found there today. So when we look at our customers and when we look at next generation sequencing, the overall turnaround time for any pathology laboratory is really critical. And so much of it depends on the preparation and diagnosis of the patient samples. So we know that if a tissue sample is not processed correctly, this can have negative effects and delay diagnosis, specifically when you're looking at those downstream molecular tests. So as mentioned, we wanted to perform this study to understand how the Revos tissue processor can produce adequately processed patient samples that allow our pathologists to have that rapid turnaround time when they need to order the next generation sequencing testing. So really from a hypothesis standpoint, we wanted to test the Revos tissue processor and to understand the hypothesis that we feel it could provide sufficient amounts, so from a concentration standpoint, of high purity nucleic acid, so that can truly influence the pathologist's ability to order those tests and understand the critical information that can come out of next generation sequencing testing, understanding the ability to diagnose the disease determine the prognostic information, and then most importantly, allowing the clinicians to select the most appropriate treatment strategy, particularly in cancer for the patients that are requiring this next generation sequencing testing. So I myself have been a histology technician for 28 years. I came into the world with my academic background in biology and chemistry, and I've had the wonderful opportunity and pleasure to work in the clinical laboratory over the past 28 years. Previous to this, I have come into the industry. I have worked for Roche doing immunohistochemistry work. I have worked for Leica Biosystems, again, doing immunohistochemistry and core histology. And then previous to coming to Apredia, I worked at the College of American Pathologists. So in my role at the College of American Pathologists, we had released the largest amount of next generation sequencing proficiency testing, really providing an indication of what's important to the anatomic pathology laboratories today. And so part of the passion that we had for doing this study from my perspective was really from a histology technician's point of view. So when my clinicians and pathologists were ordering next generation sequencing in a single test, we really wanted to understand the viability of the patient tissue after being processed on the Revos tissue processor. And so really, when we look at next generation sequencing testing, it has the ability in a single test to reveal actionable mutations. These mutations then allow our clinicians to target specific therapies for the patient. And this ultimately enables more of a personalized medicine on the patient's unique genetic profile, providing the ability to give a comprehensive diagnosis in a very short turnaround time, given that the patient tissue is adequate to do the next generation sequencing. And then most importantly, as I mentioned, allowing the clinical team to be able to select targeted therapies with this tissue at the end of this pathway. Because as many of you, I'm sure, are aware of, we do not take a piece of tissue in the beginning and always understand and know if we're going to have to perform this testing. So really, when I looked at the study and understanding the comprehensive nature that we needed to be able to provide in our hypothesis of if this tissue is going to be viable at the end of the tissue processing to do single next generation sequencing testing. So, again, as mentioned, this is very exciting for us, and this is phase 1 of our study. So just now that I've really highlighted the overall goal of the project, I just want to talk a little bit about the materials and methods and how we perform the project. And then we'll go over very briefly some of the results and then key takeaways and conclusion of the results. So, again, understanding the final point and the final phase of this will be to deliver a comprehensive white paper, not only regarding the Apredia Revos tissue processor, but comparisons of 2 other tissue processors as well. And we look to achieve this hopefully in May of 2025. So this project was really designed to compare 3 systems. And so therefore, when we look at the approach, we took each piece of tissue that was taken from a fresh harvest was divided into 3 equal parts and different pieces. Each piece of tissue was treated identically from fixation through the individual processors, and each piece of tissue was run and the routine protocols found within the factory settings of the individual tissue processors, which can be found in the operator's manuals of each of these tissue processors, and really the factory settings that they are delivered with to the anatomic pathology. Each of these pieces of tissues were then embedded and stained with H&E. Additionally, both DNA and RNA were then isolated from the processed tissue using Quingen's clinical nucleic acid isolation kit. Note, we originally wanted to only focus and perform the study on tumor tissue samples, but because, as many of you are aware, it's not always an opportunity to have a large N value of just tumor. And so it was more rare for us to get tumor tissue versus normal. So really what we wanted to do is we were able to do a mix of normal and tumor tissue, again, to avoid that hurdle of obtaining sufficient quantities of tumor samples, specifically in a clinical setting. So we divided the results, as you'll see, upcoming into two groups. So you'll see normal and you'll see tumor resections. So the data that I'm going to show you is really going to be featured around 15 normal tissue types and 8 tumor resections. These were all, as mentioned, again, grossed and cut into equal parts and processed exactly identical. Once we completed the tissue processing, we then embedded them identically, and both the DNA and RNA were isolated, again, using Quingen's formalin-fixed paraffin-embedded nucleic acid isolation kit. We chose to use this specific kit, and more details can be found in the poster, specifically because the institute that we've partnered with, Wake Forest Regenerative Medicine, clinically uses this kit, and many of our larger reference labs use this kit as well. So we felt that this was a good methodology to go forth with. And so additionally, at the end of it, and you'll see this not only in the poster, but I'll show you just a brief example of it. We then stain the tissue for H&E and digitize the tissue using the Revos or using the Apredia E1000 slide scanner to compare the overall morphology that you would be able to see in the poster. So not to get too much into the details of the data here, but essentially I just wanted to show a small yet comprehensive part of the first phase of our study. So the study was completed, as mentioned, after the DNA isolation was conducted. And the first metric that was most important to us was the DNA concentration. As mentioned, many of these samples come into the anatomic pathology laboratory, and we do not understand if they are going to need to do that downstream molecular testing. So when we look at these samples, starting with the DNA concentration, that was really important to us. And so you'll see here on the left, the DNA concentration from normal tissues. The sampling and the concentration of the DNA was isolated from each of those, and you'll see here there's a small degree of variability, but we do know that this has a lot to do with essentially the different tissue across different tissue types, the amounts of sampling, and so you'll see different variations of the sampling sizes themselves here on the left. Okay. So really the key takeaway that you'll see here on the left is that we were able to, with these normal tissues, provide sufficient quantities, really above 1,000 nanograms of extracted DNA were isolated after using the Revos tissue processor. Additionally, if you look to the graph on your right, what we're looking at here is now with that concentration of the DNA that we isolated, we then want to understand the purity. So the purity is sort of a, what we're using here in our study is an intermediate measure of quality, because again, this is the first phase of our study. One of the things, as mentioned, the end goal, we will be seeking to not only understand the concentration of the DNA and the purity of the DNA, but the next step will actually be running specific single-use next generation sequencing. So the key takeaway when you look here at the graph on the right is to understand, were we able to have usable amounts of DNA in the results? And we utilized a 260 to 280 ratio without doing the actual sequencing. This is a quality control aspect that can tell us and determine, is the DNA pure? And so again, it's essentially telling us from that isolated sample of nucleic acids, which should hopefully just be DNA within it, is this test helps us to understand when it's sitting in the buffer is how pure is it. Essentially what we do is we shine a specific frequency of light at it to look at the absorbance pattern, and we know that this should all be around 2. So what you can see here is that even though there's slight variability across tissue types. This tells us that the sample was highly pure with DNA, and really across the board here, the majority of these samples the same with a little bit of deviation above and below. Therefore, it's indicating the likelihood of being our sample is extremely pure and not contaminated with residual proteins and or RNA. Additionally, as mentioned, our goal was to ultimately use tumor tissue, but as the previous slide, we used normal. But here, this is specifically tumor tissue. This was very exciting for myself to see. Again, as a histology technician, when my pathologists and clinicians are ordering next generation sequencing testing, it's going to be on the tumor tissue. And so, again, just as previous, what you're going to see here is you're seeing a degree of variability, obviously, because of the different tissue types and different the N values of the tissue samples, but you're seeing a high degree of 1,000 nanograms or more, telling us again that we have enough of a DNA concentration post-tissue processing to perform the next generation sequencing testing. And again, here, if you look at the chart on the right, this was actually even more, what I would say is more successful on the purity of this DNA that was isolated and extracted for purity of these tissue samples. Again, using this quality metric, we can confirm not only the sufficient quantities of DNA, but more importantly, the purity of the DNA, really helping us to understand, will this tissue be successful for next generation single-use sequencing test when we get those ordered to do downstream testing on the patient sample. Just very quickly, I wanted to just show a comparative slide of morphology. So the slide on the left here was processed on the Revos tissue processor, and even more so looking at the next phase, doing the comparative on other tissue processors. Because again, as you can imagine, for our customers, we want to not only understand the outcome with our tissue processor, but we felt it was important for us to do a comparative. You'll find a great deal of comparative tissue sections in the poster. And really what we're seeing here is this is really showing an overall more uniform staining pattern, versus the comparative tissue processor, which is a little bit more washed out. Okay. Going over the results of the study very quickly. So when we look at the results of what we were able to understand, and as mentioned in the beginning, time is really important. From the time that we excise the tissue from a patient to the time that we're able to provide the clinician a diagnosis is critical. And so when we did the comparative of the tissue processors, we were able to essentially perform the processing of this tissue in 2 to 4 hours shorter than some of the other comparative clinical competitors. There's more detail that you can find in the poster about that. Additionally, when we look to the next phase of the study, we'll go more in depth with it. But essentially, what we're understanding here is the ultimate outcome of providing this high enough concentration to perform the test, but even more importantly, the purity of the nucleic acids, we were able to do that in 7 hours for the sample runs. So that's an important factor, because quite honestly, most often in the clinical lab that I worked in and managed in anatomic pathology, our tissue processing runs were taking in upwards of 12 hours, but we were able to achieve this quality of end product in 7 hours. Additionally, really understanding, as we've looked at here today, the excellent tissue processing results that we were able to see, not only for normal tissue, and we understand that typically we're never running next generation sequencing on normal tissue, but then also more importantly on the tumor resections that you were able to see in the data. And then additionally to note, there's much more comprehensive detail in the paper, the overall morphology comparison on the H&E slides was much greater in the tissue processing protocol that was only 7 hours. And then, essentially, lastly, completing and understanding the hypothesis of our study, we were able to successfully isolate DNA, and actually we even go through the RNA that you can find of the formalin-fixed paraffin-embedded samples with enough material for us to do the next generation single test sequencing and molecular testing. And then this tissue showed us the quality metric of having a high purity, suggesting, that we would have excellent opportunity or results to perform the next generation sequencing testing successfully. So in conclusion, again, we were looking in this study is both normal and tumor tissues processing on the Apredia Revos rotational tissue processor, utilizing the routine surgical program setting. And this overall demonstrated excellent tissue processing through not only the morphology, but more importantly, looking at our hypothesis, we were able to isolate sufficient quantities of both DNA and RNA, along with excellent and high purity quantities of the DNA and RNA. So this is really suggesting that when our pathologists and clinicians order those downstream molecular tests, that there is going to be the ability to perform these tests successfully on the formalin-fixed paraffin-embedded tissue utilizing the Revos tissue processor. So again, I appreciate your time today. And then just as I mentioned, what's next? Really, what's next is we're proposing to look at the actual testing itself. So we are going to take the tumor samples of the tissue that we've been working with, and we will further evaluate those on the actual next generation sequencing test. So this will pave the way for us to do a further publication on this next generation sequencing with specific notations of the tests that we'll perform. And then even further to be able to do a comparative study when we look at two other platforms of tissue processors from Socorro and Leica as really a significant step forward for us to be able to provide and articulate how will the tissue perform when doing next generation sequencing after being processed in the Revo tissue processor. So that concludes my discussion today. I appreciate again your time and thank you very much for your attention.
Thank you, ma'am, for the lucid information you gave on tissue processing for molecular testing. Any questions from the audience? Okay, no questions it seems. The study was really wonderful. We'll look forward to the phase 2 results. Thank you, ma'am.
Thank you.
Now we'll move forward. I'll welcome our next speaker, Dr. Svatslav Zinovev from Russia, to deliver a talk on artificial intelligence technologies in practical oncology. Please, sir.
Hello, do you hear me? Do you look me? Hello.
Yes, sir. Yes, sir. You're audible and visible.
Okay, let's start. Good afternoon, dear college. I am pleased to present to you a paper devoted to the study of the possibilities of using artificial intelligence technologies in practical medicine. But before moving on the real practice, let me remind you a little about the history of the development of artificial intelligence technologies. One of the first developments date to the middle of the 19th century was the intellectual tablets of the Russian scientific Semyon Korsakov. They were the forerunner for modern expert systems. It took almost 2 centuries for artificial intelligence technologies to be recognized in Russia at the state level, but it's not only bureaucrats that explain such a long journey. The concept of artificial intelligence formalized in the 1815 was originally defined as the ability of a machine to perform a task usually associated with human activity. 9 years later, the concept of machine learning appeared, which reference to the ability of an algorithm to study data and perform tasks without explicit programming using mathematical algorithms. By the end of the century, with the development of computers, linear models such as logistic regression, bicycle algorithms, dissection trees, and ensemble methods appeared. Finally, deep learning is a type of machine learning that allows you to study patterns based on raw instructed input data by including multi-level neural networks that have allowed this technology to enter various sectors of human life and, of course, medicine. Oncology is especially ready for the transformation changes brought about by intelligent artificial intelligence, given the proven benefits of individual treatment and the recognition that tumors in their response rate vary greatly from person to person. All clinical data, stage, histology, genetics must be transferred to a mathematical prism, which will allow you to choose the best way to solve a clinical problem. Unfortunately, I can ask the audience in the online format, in the offline format on the report, but at this point, I always ask a question. What do you think was the first model of artificial intelligence in oncology? The answer is simple. This is a 10M classification that combines data streams of radiation diagnostics methods, pathanatomic methods, and analysis data. Later, more complex model appear Atlas of the Human Genome, Image Archives, Oncology, DX, and Decipher, and others. Today, the FDA has approved more than 30 artificial intelligence applications in the field of oncology, including all industries, diagnosis, treatment, risk analysis, and others. I will tell you a little about some of them. A huge array of solutions for pathology anatomy, including histology, histochemistry, and cytology. A separate section is working with images, program for dermatoscopy, MRI, PET-CT. Of all this, I would like to tell you about one study on artificial intelligence technologies in cytology. In 2018, leading Industrial Research Institute of Artificial Intelligence won a tender for cervical cancer screening in Hubei province. They carried out the whole range of activities, agitation of population, most of which are rural. They hired and trained staff to take cervical swabs, purchase equipment for preparing slides and scanners for digitizing them. The schema look quite simple. Woman came to hospitals where we swab it from the cervix and place it in jar with a solution. Then the jars they're sent to the laboratory where slides were made of them, digitized, and then with the help of artificial intelligence, the division into norm and pathology of objects of interest was carried out. Of the screening woman, only 5% had positive samples. So the pathologist will need more time to detect these positive cases, and the process is more time consuming. However, when using artificial intelligence technology, the diagnostics evaluate the sample in an average of 10-11 seconds, which allowed them to evaluate 2,500 or 3,000 samples per day. After reading the study, I wondered, what is the accuracy of this technology? Before submitting for the tender, the authors of the article conduct a large study involving more than 700,000 patients. As a result, the online cytologist assessment system using artificial intelligence had 6% better sensitivity and comparable specificity than that of cytologists when detecting cervical intraepithelial neoplasia of the 2-degree and more severe lesion. There are also applications for endoscopy, computed tomography, and of course, mammography. I pleased to present to you a paper entitled Artificial Intelligence as a Factor in Improving the Effectiveness of Digital Mammograms in Breast Cancer Screening, the results of the works of the Reference Mammography Center. As we all know, mammography is a gold standard of breast cancer screening. However, in almost all countries, we face the same problem, lack of human resources and insufficient experience of a radiologist. The purpose of our study is to evaluate the possibilities of using artificial intelligence to improve the quality of breast cancer screening and improve the detection of local breast formation by forming a target sample of screening mammograms for revision in reference centers. Project objectives to identify things of focal information in the mammary glands throughout the analysis of artificial intelligence mammograms performed in 2019, evaluation of the effectiveness of the artificial intelligence platform for the detection of local formation, including breast cancer on BI-RADS screening mammograms 1-2 to confirm the effectiveness of the use of this artificial intelligence in implementation of quality control measures for radiological service for the rests of description of mammographic studies and the formation of targets sample for their revision. The study included 3,110 pieces of mammograms performed in 2019 and interpreted by radiologists of non-oncologist institutions. All mammograms were performed in small hospitals on digital mammographs and fall under BI-RADS 1-2, that is the norm. The screening period in 2019 exclusion criteria BI-RADS 0, 3, 4, or 5. We used the Celsius software program. It's intended for automatic analysis of digital medical images of mammographics and fluorographic studies with subsequent interpretation of the results. The software analyzes image in DICOM format for mammographics examinations. 2 or 4 images must be uploaded to the system. The interpretation of the results is somewhat different from the classic 5-step BI-RADS. Celsius was created just for primary screening and in place, in fact, and diskette answer, it's were a pathology or not. Out of 3,110 cases, 210 were excluded as defective in modality. Of the remaining 2,800 cases, 398 were marked by artificial intelligence as suspicions, and 2,511 cases as normal. Both groups were analyzed throughout the patient accounting system and reviewed by radiologists of our center. At the time of the study, 2023, Not a single woman from the normal group had applied to the oncologist center, and no discrepancies in diagnosis were relevated during the revision. Out of 398 cases marked with a red flag, 25 mammograms were transferred to BI-RADS-free. 79 mammograms showed change in artifacts. 2 cases of early stage breast cancer were detected. Look in the picture, it's 2 patients. And 283 mammograms remained in the BI-RADS category. In this slide, you can see a comparison of the classical system and artificial intelligence system in different categories. Banked pathology is marked in green. And this slide shows how the system marks out suspicion errors. It's a red. As a result, false negative cases are 0%, and I must say that is an ultimatum indicator for us. Artificial intelligence should not miss pathology. Overdiagnosis is acceptable. False positive 12%, true positive 93%. After receiving these results, we wrote about it. What is the application point for this technology? In many regions of Russia, there are reference centers for the revision of mammograms and in pathologies in order of increase the detection of breast cancer. The main task of the reference center is to review 10% of mammograms of categories BI-RADS 1, 2, sent by medical organization of the region, and 100% of mammograms of categories BI-RADS 3, 4, 5. As well as to obtain a third option in Federal Reference Center. It should be noted that the sample of 10% of the conditional norm is carried out empirically by radiologists and cannot be reliable. The CELS program just allows you to select the sample of normograms necessary to increase the detection of breast cancer. Thank you very much. I say for us maybe 10 minutes. Thank you.
Thank you, sir, for your informative presentation on artificial intelligence in cervical and breast carcinoma. Sir, which software are you using actually for artificial intelligence?
Very bad connecting.
Which
Maybe
software?
Can you written this and I make an answer?
Sorry.
Hello?
Okay. Any questions from the audience? Okay, no questions it seems. Okay, thank you, sir. I will invite our next speaker now, Dr. Balwant Singh Gill from India. He will deliver a talk on pathophysiology and management of esophageal varices in current practice. Please, sir.
Am I visible?
Yes, sir, you are visible. PPT is also visible.
Good evening, everyone. Thank you very much for inviting me in 14th World Gastroenterology, IBD and Hepatology Conference held at Dubai. I, Dr. Balwant Singh, Director and Head Department of Gastroenterology, Hepatology and Interventional Endoscopy, Institute of Liver Gastroenterology and Pancreatico-Biliary Sciences, SGRD Hospital, Punjab, India. Now I am presenting my talk on pathophysiology and management of esophageal varices in current practice. First, we have to know about esophageal varices. Esophageal varices are dilated submucosal distal esophageal veins connecting to the portal and systemic circulation. This happens due to portal hypertension, most commonly a result of cirrhosis, resistance to portal blood flow, and increased portal venous blood inflow. The most common fatal complication of cirrhosis is variceal rupture. The severity of liver disease correlates with the presence of varices and risk of bleeding. Symptoms require a medical diagnosis. Usually, there are no symptoms unless the veins bleed. Symptoms of bleeding esophageal varices include vomiting blood, tar-like or bloody stool, melena, in severe cases, shock. Who may experience gastrointestinal bloating, blood in stool, dark stool from digested blood or vomiting blood. Most commonly, bleeding, difficulty swelling, it's called dysphagia, enlarged veins around belly button, flapping, hand tremor, or web of swollen blood vessel in the skin. Bleeding esophageal varices. No single treatment for bleeding esophageal varices is appropriate for all patients and situations. An algorithm for management of the patients with acute bleeding is presented.
Excuse me, sir. Can you please slide show your PPT?
Have you seen?
It is not full screen yet. Can you please full screen it?
Yes. No?
Still the same. Sir, there is option slideshow on the top, na?
Just a minute. No.
Yeah, near the animations.
I'm not getting.
Just near the animations, there is slideshow on the top. Or you can just full screen it.
This is full screen on my PC.
Okay. Can you share your screen again? Yeah, this is better, sir. You can continue.
Bleeding esophageal varices. No single treatment for bleeding esophageal varices is appropriate for all patients and situations. An algorithm for management of the patient with acute bleeding is presented in this article. This option for long-term definitive therapy and the criteria for selection each are discussed. Pathophysiology and management of esophageal varices. Esophageal varices are one of the most common and severe complications of chronic liver disease. New aspects in epidemiology, pathogenesis, and treatment of varices are viewed. Sclerotherapy is the first-line treatment for acute hemorrhage. Prevention of first or recurrent bleeding is still unsatisfactory. Beta blockers are slightly superior to sclerotherapy with regard to prophylaxis of first bleeding. Beta blockers or sclerotherapy may be used for prophylaxis of recurrent bleeding. However, prophylactic treatment regimes do not have a major impact on survival. Combination treatment, new drugs, or new devices may help to improve the efficacy of prophylactic measures. Treatment consists of beta blocker. Treatment include a beta blocker medical procedure to stop bleeding and in rare cases liver transplant. Medication, beta blockers, synthetic hormones, antibiotics and blood transfusions. Medical procedure, nasogastric intubation, rubber band ligation, sclerotherapy, transjugular intragastric photosystemics and balloon tamponade and therapeutic endoscopy. Supportive care, in these cases, IV fluid, delivering fluid medication or blood directly into a vein. Endoscopic therapy for esophageal varices. You can you can see in these pictures among therapeutic endoscopic options for esophageal varices, endoscopic variceal ligation, EVL have proven more effectiveness and safety compared with endoscopic sclerotherapy and is currently considered as first choice. In acute esophageal varices bleeding, vasoactive therapy either with terlipressin or somatostatin prior to endoscopy improves outcomes. Moreover, antibiotic prophylaxis has to be generally adopted. Varicose glue injection, cyanoacrylates seems to be effective in treatment of esophageal as well as in gastric varices. Prevention of rebleeding can be provided both by EVL alone or combined with non-selective beta blockers. Moreover, EVL can be adopted for primary prophylaxis with no differences in mortality compared with drugs in subjects with large varices and unfit for a beta blocker regimen. A meta-analysis of endoscopic variceal ligation for primary prophylaxis for esophageal variceal bleeding. Despite publication of several randomized trials of prophylactic variceal ligation, the effect on bleeding-related outcomes is unclear. We performed a meta-analysis for the trials as identified by electronic database searching and cross-referencing. Both investigators independently applied inclusion and exclusion criteria and abstracted data from each trial. Standard meta-analytic techniques were used to compute relative risks and the number needed to trial. For first variceal bleed-related mortality and all-cause mortality. Among 600 patients in 5 homogeneous trials compared prophylactic ligation with untreated controls, relative risk of first variceal bleed-related mortality and all-cause mortality were 0.36 out of 0.26, between 0.5, 0.20 out of 0.11 to 0.39 and 0.55 out of 0.43 to 0.71 with respective NNT NNT of 4.1, 6.7 and 5.3 respectively. Among 283 subjects from 4 trials comparing ligation with beta blocker therapy, the relative risk of first variceal bleed was 0.48 out of 0.24 to 0.96 with NNT of 13. However, there was no effect on either bleed-related mortality, relative risk 0.61, confidence interval 0.20 to 1.88, or all-cause mortality were 0.95, 0.56 to 1.60. In conclusion, compared with untreated controls, prophylactic ligation reduces the risk of variceal bleeding and mortality. Compared with beta blockers, ligation reduces the risk of first variceal bleed, but has no effect on mortality. Prophylactic ligation should be considered for patients with large esophageal varices who cannot tolerate beta blockers. Subsequent research should further compare ligation beta blocker to determine the effect on mortality and measure ligation's cost effectiveness. Thank you. Thank you very much.
Thank you, sir, for the insightful presentation. Anyone wants to ask any question, you can proceed in the audience. There is no question, it seems. Thank you, sir. Now we'll proceed further with our next poster presenter, Dr. Seema Singhal from the United Kingdom. She will discuss a case report on microglandular adenosis. Please, ma'am.
Thank you very much so much for inviting me here. I'll share my screen.
Sure, ma'am.
Is it visible?
Yes, ma'am, it's visible.
Yeah. Okay. Yeah, so today I'll be sharing and discussing one case of macroglandular adenosis, which I reported with my student, Dr. Alesha. Yeah, so why this case I have chosen for presentation and what is the importance of microglandular adenosis. It's a benign rare lesion. Although benign and it is rare, but morphologically, it and even radiologically, it may mimic malignancy. And on sometimes it's very confusing on immunohistochemistry as well. So to differentiate it from invasive malignancy, it is important to have awareness of this entity, and it also progresses to atypical forms and carcinoma arising in microglandular adenosis. So it is we had a discussion in the team and found this case quite interesting to report. So what is microglandular adenosis? Morphologically, it is comprising of small, uniform, round glands, which are composed of single layer of epithelial cells. So what is the difference between a benign and malignant glands morphologically? Usually the invasive malignancy has irregular contours and lack of myoepithelial cell layer, and has invasive fronts. So we can see invasive invasion in fat or stroma. Similarly, these glands lack myoepithelial cell layer, and also they can be seen infiltrating in stroma and fat, although there is no stromal reaction surrounding them. So they might be confusing on initially seeing the slides, but careful workup, you can pick it up. So our case was an 83-year-old woman who presented with a palpable breast lump. Radiologically, it was a 22 millimeter irregular density with speculated margin. Core biopsy showed it to be a ductal carcinoma in situ with duct carcinoma and with focal lobular features. And she had WLE after that. WLE showed ill-defined tumor, approx to 32 millimeter in size. And this was the report which was given. On microscopy, the lesion comprised of invasive carcinoma, definitely, but along with we also appreciated these areas which are comprising of small round tubular structures which were lined by bland cuboidal cells, and no myoepithelial cell layer was appreciated, and they were having eosinophilic secretions. On immunohistochemistry, these cells lacked P40 stain. So no myoepithelial cell layer could be seen around these cells. However, they showed dense diffuse positivity for S100. That is what is more characteristic for microglandular adenosis. Along with that, we also appreciated complex cytological atypia and complex architecture in microglandular adenosis. So it was transforming into malignant condition in surrounding tissue. So this was the invasive cancer. This is the invasive cancer, and this is the microglandular adenosis. So we can see the difference. This is the S100 stain. So S100 stain is beautifully highlighting adjacent microglandular adenosis, and this stain is lacking in the invasive component. And this is the papillary carcinoma, which was also there. This case was reported as grade 2 duct carcinoma and invasive papillary carcinoma with DCIS, and microcalcifications were present in the vessels. The tumor was measuring up to 20 millimeter, and the background breast shows microglandular adenosis and also atypical microglandular adenosis. This was hormonally, it was ERPR positive, HER2 low. So in this case, the tumor was exactly 20 millimeter, but microglandular adenosis was 26 millimeter, overriding even the tumor. So exact size of each component is important for staging of the tumor, invasive tumor. So that otherwise it could lead to wrong staging. And the hormonal status in this patient is like they are ERPR positive. So tumors which arise from microglandular adenosis, they are usually triple negative, or they could be NST or adenoid cystic carcinoma, spindle cell carcinoma, matrix producing carcinoma, or ethnic cell carcinoma. So So although it is a benign rare entity and harmless benign entity, but because it can progress to atypical forms and cancer, even if it is um, so even if it is biopsied on a core biopsy, WLE should be performed to look for any coexisting invasive carcinoma or any atypical microglandular adenosis progressing from that lesion. So to conclude, it's a rare benign lesion which can mimic invasive carcinoma, and it can progress to atypical microglandular adenosis and various types of invasive breast cancer. So this our case discussed the microglandular adenosis with foci of atypical microglandular adenosis, DCIS, IDC, and invasive papillary carcinoma. Immunostains are definitely helpful. So S100 positivity and lack of basement membrane staining, it highlights that is differentiates from the invasive carcinoma. And like I already discussed, core needle biopsy, if it is diagnosed in core needle biopsy, it should be completely excised to it can because to maybe to see the associated tumor or its tendency to progress to cancer. And it's awareness among pathologists and clinician both is essential to avoid misdiagnosis. Thank you so much for your kind hearing. These are my references.
Thank you, ma'am, for sharing such a rare case. Anyone wants to ask any question from the audience? There are no questions, it seems. Now I'll request Dr. Seema to continue chairing the further sessions.
Yeah. So good afternoon, everyone. Thank you very much. Thank you so much. And first of all, I thanks everyone to be on this virtual mode and making this event successful. It's very difficult to join in different time zones all over the world, but yes, here we are making this successful. So I'm Dr. Seema Singhal. I'm working as consultant histopathology in Maidstone and Tunbridge Wells NHS Hospital in UK. And so today, now I welcome our next poster presenter, Miss Claudia Andrea Arias from USA, and she'll be presenting on smart dentistry, exploring the potential of AI in oral healthcare. So over to you, Miss Claudia. Miss Claudia, are you there in the conference? We'll wait for some time. Maybe get a message. Okay, so she's not available in Zoom meeting. So I welcome the next poster presenter, Dr. Homagni Sikar Roy from United Kingdom. And I kindly invite her to present worsening jaundice secondary to hepatic amyloidosis, a case report.
Hello, this is Dr. Homagni Shikhar Roy. I'm working as an internal medicine trainee doctor in North Wales currently. I'm not sure, am I audible?
Yes, you are very well audible. Okay. Thank you so much.
Thank you.
Yeah.
Let me try to share my screen.
Yeah.
Can you see my presentation? I can't hear you. Sorry. I think my
Yeah, we can. I can see your presentation. Is it from a phone?
Yeah, it is from a phone.
So can you make it a slideshow? I think it will be bigger then.
Slideshow. What about this one?
Yes, it's better. Yeah.
Okay then. Yeah, thank you so much for that help. So my topic today is worsening jaundice secondary to hepatic amyloidosis. It's a case report. So the presenting complaint was it was an 84-year-old female who was admitted with jaundice, right upper quadrant pain, and deranged liver function test. I would like to declare that there is no conflict of interest in this study. Presenting complaint with 3 points really: jaundice, right upper quadrant pain, deranged LFTs. When we go into a little bit of the history for the presenting illness, there was like 4 weeks of history of jaundice. There was almost 3-day history of right upper quadrant pain. There was no report of any fever, and the patient did report some weight loss and reduced appetite. In the past medical history, there was a pancreatic IPMN, which is intraductal papillary mucinous neoplasm, which is actually a benign neoplasm of the pancreas, which has been stable for the patient for the last few years. She also had hypertension and an ovarian cyst, which was again stable and was under follow-up by the gynecologist teams. And she also had diverticulosis in the past. She was allergic to amlodipine and perindopril. Her medications that she used regularly was losartan and paracetamol. There was nil significant family history. Socially, she lived with her husband. There was no recent travel history, and she didn't smoke or drink. When we looked into the physical examination, observations-wise, she was completely stable. There was no fever, no hypertension. Her heart rate was fine. She was saturating normal, and she had a normal GCS of 15 out of 15. She looked very tired, and we did notice some scleral icterus and jaundice. Heart sounds on examination were normal. Chest was clear. On abdominal examination, we did notice right upper quadrant tenderness and hepatomegaly. There was no splenomegaly. And there was no edema in the lower limb. Then we looked into a few investigations. The initial set of investigations that we did were routine set of bloods that involved liver function test. The basic liver function tests were deranged in the fact that it showed a cholestatic or obstructive picture.
I'll come to you. Yeah, sure. Thank you.
Sorry, was it for me?
I'm sorry. No.
Oh, okay. So the initial set of bloods that show that there was a deranged LFT, and initially it was like high bilirubin and high ALP. We did do a GGT, which was found to be raised as well. A non-invasive liver screen was done, which was mostly negative. All the cancer biomarkers were done, which were all negative except CA19-9, which, if we remember, is a marker for pancreatic carcinoma. But CA19-9, just to remind ourselves, can also be high in someone with a benign pancreatic mass like IPMN also, which she has a past medical history of. So followed by the bloods, we did a CT tap, which showed the stable pancreatic IPMN appearance. That is, there was no increased size or anything. It is same as the previous scans that she had yearly. There was bilateral adnexal cysts, and there was cholecystitis. For the bilateral adnexal cysts, we did refer her back to her own gynecologist, who said there was nothing that needed to be done at that moment, but because that looks stable. And for the cholecystitis, we referred to the surgical team in our hospital. We also did the ultrasound abdomen initially, which showed multiple gallbladder calculi. And this was followed by a MRCP, which again showed cholecystitis and stable pancreatic IPMN. And for the cholecystitis, I already said we referred to the surgical team, who did say that this will be for conservative management given her age and her poor performance status. Due to the worsening jaundice and the worsening LFTs during this admission, this was roughly a 2 to 3 weeks admission. We had to do further investigations. We did a second ultrasound abdomen, which showed that the liver has enlarged by that time, and she developed moderate ascites. It was causing her to have difficulty in breathing. And when we couldn't find out any other cause, we did end up having a liver biopsy, which showed and actually gave us the diagnosis. So basically, it showed a diffuse and striking amorphous pink material, which was distributed throughout the liver sinusoidal spaces. And that was very typical of the appearance of amyloid deposition. And Congo red diffusely was positive with birefringence. The diagnosis is hepatic amyloidosis, as you might have already understood by now. So it's a systemic AL, that is amyloid light chain amyloidosis, is characterized by extracellular deposition of the protein in many organs. It's a rare case of hepatic amyloidosis. It's presenting as a progressive jaundice and cholestatic blood pattern, has been reported here. So management-wise, initially when we found the cholecystitis, I did mention we referred to the surgical team who advised conservative management. Then when in the second set of ultrasound abdomen we found ascites, we did do a acidic drain. And that was purely to provide some comfort for her, because by the end of second week and the beginning of third week, she started deteriorating quite rapidly. For her poor nutrition, she wasn't able to eat or drink anything. Given her fatigue and her weakness, she wasn't able to tolerate orally. We involved the dietitians. Initially, they tried to increase her oral intake, which didn't help much. So we ended up putting an NG tube for her. After the diagnosis, we involved few teams, our local oncology hematology team and our local liver unit, which is in Birmingham. And as per all the teams, given her poor baseline, she was deemed unsuitable for transplantation and was considered for conservative management. So basically what happened after this was she was in the hospital for 1 more week and she deteriorated stably and was placed on a comfort care pathway, and she passed away peacefully at the end of it. So what clinical lesson we learned from this study is that there should be a high index of suspicion for hepatic amyloidosis as one of the potential causes of worsening jaundice, especially in patients who present with deranged LFTs, jaundice, and some vague abdominal symptoms. Thank you for this. Any question would be welcome.
Thank you, Dr. Himakni. Yeah, any questions from the audience, please? So I just wanted to know, are there any radiological any suggestions we can early pick up amyloidosis, or and what would be the treatment if this patient had been picked up early? Could we save her?
So radiologically wise, we would, for anyone with deranged LFTs, the guideline is first we go for abdominal ultrasound. If it shows CVD dilatation or stones, then we go for MRCP. If the MRCP does show any stone blocking the pathway, then we go for ERCP. But that's for one of the general things. For amyloidosis, we don't see anything typical of imaging, but it can show that it can present as someone having stones or cholecystitis. Treatment-wise, for someone who presents early on and is suitable from all aspects, would be considered for liver transplantation. Because hepatic amyloidosis is something where the amyloid has already been deemed to be deposited across the liver. So liver transplant would be the only treatment for that patient.
So it's like early pickup in radiology is also not there. So maybe biopsy.
Yeah, biopsy is the only way to diagnose hepatic amyloidosis.
Yeah. So it's really interesting and insightful case, Dr. Omani. Yeah. Thank you so much.
Thank you so much. Mm-hmm.
Okay. So now I would like to present our next speaker, Dr. Yusuf Essi from Israel. He's presenting a speech on bone marrow sarcoidosis with immune thrombocytopenic problem.
Hello, everyone. Do you hear me?
Yes, Dr. Yusuf, you're audible. Thank you.
That's great. I'm going to share my screen now. Do you see my screen?
Yeah.
Okay, great. Let's start. Okay, here we are. First of all, I would like to say hello to everyone, and I would like to introduce myself. I am Dr. Yusuf Assi from Israel. I am a graduate of Julio Hatiganu University of Medicine and Pharmacy in Cluj-Napoca, Romania. I also work with a research team in Tel Aviv University in Israel, and I hope you find my research, my presentation interesting. I have a short presentation about my final paper, my recent paper. It's about bone marrow sarcoidosis with immune thrombocytopenic purpura. Please stop me if you have any questions or if you have any comment. So we start with sarcoidosis. What is sarcoidosis? Sarcoidosis is a multi-system inflammatory disease characterized by the formation of granulomas. It can affect various organs, most commonly the lungs and the lymph nodes. Just a second, because I found a problem here with sharing my screen now. The first described by Dr. Jonathan Hutchinson in 1877, and prevalence rates vary globally, and higher incidence was found in Scandinavian countries and African Americans. It's rarely seen in Asians. Causes and risk factors. Genetic predisposition is the main cause of the sarcoidosis. We have also environmental triggers, and also lifestyle and occupational risk play a very important role. Genetic predisposition, like familial clustering, suggests a genetic component. Specific genes mutations linked to increased susceptibility, and research ongoing to identify the precise genetic markers. Environmental triggers like infections and exposure to organic and inorganic agents. Lifestyle and occupational risks like occupations like firefighters or construction workers. Also people with who smoke or with a stressful lifestyle or stressful job. It's also a risk factor. It's also a very important risk factor. The pathophysiology of the sarcoidosis response to pathogenesis. We see overactivity of T helper cells noted in the sarcoidosis patients. Inflammatory cytokinase play a significant role as well. Formation of granulomas. Granuloma formation is a hallmark of sarcoidosis. They disrupt the normal tissue and are made of organized collections of macrophages. Organ system impact. We see pulmonary involvement in is the most common and the most severe. We also see skin, eyes, heart, and nervous system involvement in sarcoidosis, but the most common is the pulmonary involvement. Respiratory symptoms, we see chronic cough. We hear a chronic cough, a persistent cough lasting longer than 8 weeks. It can be dry or productive with mucus, and often worse at night or in the early mornings. Also, the patient will experience dyspnea, a difficulty of breathing during the physical activity, shortness of breath at rest, and in severe cases, and also increased effort required to breathe. So he's really have a heavy feeling in the chest. Also, the patient will experience chest pain, like a sharp, like this, or stamping sensation in the chest, and may worsen with deep breathing or coughing. Systemic and non-respiratory symptoms. Patient may experience fatigue, general malaise, fever and night sweating, and also weight loss. Organ-specific manifestation. In cardiac involvement, there is palpitations and irregular heartbeats. Ocular symptoms like blurred vision or double vision with eye pain and discomfort, redness or inflammation of the eyes, and dermatologic signs like rashes, lesions, itching, or discomfort of the skin, changes of the skin color. I will go back a bit. For the cardiac involvement, I would like to add also symptoms of heart failure, like swelling of the ankles and the feet. Clinical evaluation. Each patient comes to the clinic or to the doctor. We make, as a doctor, a clinical evaluation. We start with physical examination finding, patient history assessment, and symptom-based differential diagnosis. In physical examination, there is 4 important components or 4 important points, like inspection of the signs of respiratory distress, palpation to detect abnormalities such as lymphadenopathy, percussion to assess the presence of fluid in the lungs, and auscultation for abnormal breath sounds like crackles or wheezing. Patient history assessment, we collect all the data, all the medical history, including post-illnesses, treatments, surgeries, all the family history, everything about the patient. And now we have many diagnoses, many possible diagnoses, differential diagnoses, and we start to eliminate. We start to analyze and eliminate the possible and the impossible diagnoses that could be in our patients. We rely on imaging techniques in sarcoidosis, mostly on chest X-rays, high-resolution CT scans, and PET-CT scans. Laboratory tests and procedures. We rely on blood tests, measurement of angiotensin converting enzyme levels to diagnose sarcoidosis. TBC, a complete blood count to evaluate the anemia or a presence of infection. Also assessment of inflammatory markers such as ESR and CRP. ESR, erythrocyte sedimentation rate, CRP, C-reactive protein, that can show us presence, like a presence of inflammatory, it's inflammatory markers actually. It's can tell us if there is inflammation or not. As well as testing for antibodies. Pulmonary function tests may include spirometry to measure lung volumes and airflow rates, diffusing capacity tests, and inhalation challenge tests. We also do biopsy and send it to histopathology to identify a tissue abnormality through a microscopic examination using bronchoscopy to obtain bronchial or transbronchial biopsies, video-assisted thoracoscopic surgery for obtaining lung tissue samples, and immunohistochemical staining to identify a specific cell types. Pharmacological treatments, include corticosteroids, immunosuppressive agents, and biological therapies. We also have to, in this part, we have also to focus on the complications after using corticosteroids, immunosuppressive agents, like in corticosteroids, the patient may experience for a long term bone lesions or striae in the abdomen. In immunosuppressive agents, the patient may experience inflammations. Many diseases can be be a patient a host to many viruses. So we have to compare which is the benefits and which is not the benefits to use for each medication. So we, at the end, can choose the best for the patient, which is the best treatment is condition. And in some patients or in some occasions, we can mix corticosteroid suppressive agents and biological therapies. It depends on the condition we have, on the situation, on the severity of the disease. Many factors play a role. Non-pharmacological interventions like physical therapy, respiratory rehabilitation, and nutritional support. We have also surgical treatments, like organ transplant, surgical biopsies. If the medical treatments didn't work out and the non-medical treatment, non-pharmacological treatments also didn't work out and the patient still have the symptoms and there's no improvement, we go to the surgical treatments. You can see here in the picture, in the second picture, there is a surgical biopsy. Disease course and outcomes, acute or chronic sarcoidosis. Most patients still have the sarcoidosis after 3 years, are likely to have a chronic disease. It's very important. This part is very, very important. Patients who still have the sarcoidosis after 3 years, it's likely to have a chronic disease. Remission rates during follow-up, continuous remission rate was 20.2%, pulmonary hypertension development, and mortality rate 4.25%. In long-term management, we monitor and follow up the patient, and we recommend frequency of checkups, adjustments based on the disease progression before. We make adjustments on the treatments based on the diagnosis and the disease progression. Relapse prevention, maintenance therapy options, and monitor lifestyle factors, prevent relapses, and lifestyle modifications like healthy diet, exercise daily, stress management, and giving emotional support to patients. It's very, very important. It's so important for them. We always tell this to the patients that the healthy diet, exercise, stress management is very important. Complications, we can see complications in sarcoidosis, in pulmonary sarcoidosis, like pulmonary hypertension and fibrosis. In cardiac sarcoidosis complications, heart failure, sudden cardiac death, ventricular arrhythmia, myocardial infarction, and AV block. And nervous system involvement maybe dementia, decreased of hearing, loss sensation, dizziness, psychiatric disturbances, and headache. Like the patient may have one or more symptoms, depends on each patient. Current research trends, advances in genetic research, new genetic markers identification genome, and new therapeutic targets like development of small molecule inhibitors to control the disease, exploration of immune checkpoints inhibitors, and third, developments in diagnostic imaging, like innovations in MRI and CT scans, advancements in PET imaging, and introduction of AI, artificial intelligence, in imaging analysis. Future treatments, like biological treatments, monoclonal antibody treatment, or cell-based therapy, gene therapy potential, advances in technology, editing techniques, and clinical trial progress, personalized medicine approaches to genomic profiling for treatment customization. So this treatment will be personalized for this patient, is specific for him. It doesn't work for other patients based on the genes, on the all the data we have about the patient, the symptoms. So we look on the gene profile here. Advocacy and awareness, public awareness campaigns in social media, educational initiatives, collaborations with influencers and famous people, for example. Medical conference as well, it's very important, like we do what we are doing right now. It's very, very important for public awareness. Patient advocacy groups to support networks and resources, and also support research funding by lobbying for increased research awards partnerships. Here I have a short case. We have a male patient, 36 years old, no medical history, symptoms at admission, fever, flu-like symptoms, generalized weakness, ecchymosis, and easy bruising after minimal traumas. So for example, if he hits himself by a mistake like this, or with a table, with any minimal trauma, he will have ecchymosis and bruising over his body. Diagnostic approaches, CPC, a complete blood count, showed a low platelet count. A blood showed ITP, immune thrombocytopenic purpura, and bone marrow biopsy revealed a slightly hypocellular marrow with adequate megakaryocytes. Here's a CBC of the patient. As you can see, the platelets count is very, very low. It's 12,000. The normal range is from 150,000 to 450,000. Remember this range, please, for the next slides. Here we have a chest X-ray. 1 month later, a chest X-ray was done, showing a bilateral mediastinal lymphadenopathy. I will give you a couple of seconds to look on the picture. And biopsy performed and confirmed the presence of sarcoidosis. Moreover, imaging studies were remarkable for a mild splenomegaly and mediastinal lymph nodes seen with CT scan. So our final diagnosis was bone marrow sarcoidosis with immune thrombocytopenic purpura. Treatment started with prednisolone, 1 milligram per kilogram, but he only showed a partial improvement, followed by a mild tendency to bleed from the gums and the nose. He received also 4 doses of IV intravenously dexamethasone, 1 milligram, which produced a transient effect followed by another drop of platelet count. He was with platelet count of 12,000 and he dropped after that, the count. Afterwards, the patient received 2 grams of IV immune globulin for 5 days, followed by weekly rituximab intravenously, 1 gram for 4 weeks without improvement. He was following up with a pneumologist for the sarcoidosis and was on cyclosporine 100 milligrams per dose for 6 months. The patient's platelet count remained without any improvement, so he received a multiple platelet units. And bone marrow biopsy again showed a hypocellular bone marrow with multiple granulomas and multinucleated giant cells with astroid bodies. The patient recently received electrombobag, 25 milligrams, and the dose was increased to reach 50 milligrams for higher efficacy, and platelet count were finally improved to reach 130,000 after electrombobag. So we started with electrombobag 25 and then increased to reach 50 milligrams, so twice higher, and the improvement were seen after this. The platelet count is increased to 130,000 from 12,000, if you remember from the beginning. Treatment, the patient remains under follow-up and the treatment plan will be adjusted as necessary. It depends on his condition, what symptoms he will have, the progress of the disease, the risk factors, everything. So here we reach the point where you may have a questions. If you have a questions, please ask me. I'm here for you to answer any questions. Do you have questions? Anyone have question?
Yeah, thank you. That is a good, very detailed presentation of your case. Only I had just why selective thrombocytopenia was. Is there any reason like the granulomas could it could be a pancytopenia? So is there any could we find any reason for selective thrombocytopenia?
First of all, it was the patient came, as I said in the beginning, with ecchymosis and bruising. And we made a CBC, a complete blood count, and it showed a drop in the platelets. And after that, after 1 month, we made a chest X-ray. We saw a bilateral lymphadenopathy, and we suspected sarcoidosis. So we made a bone marrow biopsy, and bone marrow biopsy confirmed the results. So after that, we saw in the histopathology, the granuloma, the histopathology confirmed the results with the sarcoidosis.
Yes,
I
yes.
hope I answered your question.
Yeah, yeah. Thank you so much. Thank you. Thank you for
You're
the nice
welcome.
presentation.
Thank you. At the end, I would like to thank you. Thank you all for your attention. And I wish everyone a good stay in Dubai and have a wonderful Christmas and New Year holidays for everyone. Thank you. Thank you, Dr. Sima.
Thank you. Thank you, Yusuf. So now I present our next presenter, Ms. Claudia Andrea from USA. She'll be presenting on smart dentistry, exploring the potential of AI in healthcare.
Hi, good morning. Sorry for my voice. I have a flu at the moment. Is the reason that I stay at home.
Okay. Just
Can you
don't
guys hear
stress.
me
Yeah,
okay?
we can hear you. Don't stress yourself. So be just, we can hear you very well. Be soft and you can continue. Just make it a slide show so we can see the full.
Can you guys see my presentation here?
Yes. Can you make it a slideshow as well?
Excuse me?
Slideshow? Can you make it a slideshow?
Yeah. Mm. Can you see it now?
Yeah, right. Perfect. Thank you.
Okay. As she said, my name is Claudia Andrea Arias. I'm original from Colombia. I'm foreign dentist living here in Massachusetts and United States. And today I would like to talk about smart dentistry, exploring the potential of AI in oral healthcare. As we know, AI is everywhere, is not something new, but at the moment we are having a new tools that we can use as a dentist. I would like to start with what is AI. AI is a computer or software that need to be used for a human, that we can send the information that we need and that can help us to have something like a some tasks that include like a decision, understanding natural language, and solving complex problems. When I'm talking AI in healthcare, uh, we are including programs that help the dentist and the dental hygienist with diagnostics, treatment planning, and patient care. When I'm talking about diagnostics in the future, I'm gonna show you a presentation with simple cases that I would like to show you how dentists can determine if the tooth have a big cavities, and it's so easy to show to the patient because sometimes we are speaking in a science language, but the patient don't understand what's going on inside of the mouth. This one help the dentist to increase the volume of patients because patients nowadays they are so digital and they love when you show in the computer what's going on in the mouth. When we are talking about application in dentistry, as I said, in the past we have X-rays, but nowadays we have digital X-rays that is so easy to put inside of the mouth, and also that help to the patient to show right away. This one have less radiation than the X-rays in a long time ago. Also, we have a CT scan that help to to show us and explain the patient what he needs, a big surgery, what he don't has, the patient doesn't have any bone, and also we use a system to detect cavities, periodontal disease, that we can show the patient the difference between a healthy gum, a healthy bone, and difference between periodontal disease that when the patient lost a lot of bone. Also, we can show oral cancer and abnormalities in their mouth. Here is the example that I want to explain you guys the difference. If we see in red, this one is going to be the cavity. And if we put it here, we see how deep is the cavity inside of the tooth. Also, if you see the blue one, it's gonna be the enamel. The enamel is the superficial layer of the tooth that these ones mean that the cavity is really deep. And the green one is the dentin, that is the second layer. The yellow is the pole, that is the nerve that have vascularization. And the orange is the metal restoration, that is the amalgam, and the sky blue is a restoration, a composite that the patient already has in the mouth. Here is the most important thing, that when we can use this one to show the patient, now they understand a little bit more, because when we open x-rays, as a dentist, we can see right away what is the cavity, but for the patient, it's a little bit of confusion, because they can see this dark circle here, and they see this black here, and they can see like, oh my God, my cavity is so deep onto the nerve. And also, we are doing clear aligners that before we use our orthodontics braces, but this one is depend of the case, because sometimes some cases are a little bit more complex, and we can treat the patient with aligners. Is the reason that the first appointment we like to spend a lot of time with the patient. The patient understand what's going on, what is going to be the procedure, and for that we use a CAD CAM. The CAD CAM is an application of computer design and manufacturers, that if you guys see this one here, that help us to scan the mouth and take photos inside of the patients to show the patient and represent the bite that the patient have at the moment. And that way we can show the patient how much forces the patient make at night when he eat, and we can use this one. And also we have another program with the same scanner that'll help us to do a surgical assistant in implant dentistry. Nowadays, for implants, it's a little bit more accessible, because we can use a guide to place the implants, and we can already plan all the treatment that we are going to do to the patients. That help us to have a precise planning for surgery and optimize time and the placement for the implant. This one is an example of the new robotic surgery that we have at the moment. That's called Jomi Assist, that help us just to hold this part here. We already have the CT scan for the patient, and this one is the nerve here that let us know how deep we can place the implant. Also, if you put it like a different way, the robot it's gonna angulate again your position, because it's already in the computer, and the robot already knows how you have to angulate to don't get any mess.
Into the precise angle and position. Yomi prevents any deviation from the plan. With full view of the surgical site, the surgeon precisely drills the osteotomy and is stopped when reaching the planned depth.
And at that point, we know until what point we can put the implant.
Through seamless integration into the surgeon's operating environment, Yomi achieves a truly digital dental workflow. Yomi, accurate.
Okay. And when we're talking about patient management and interaction virtual assistant, we can see we can help our dental office with the schedule appointments. That means that the software can send automatic message to our patient to let them know what they need, what time they miss the appointment, and we can help also with the treatment advice. That is going to help the front desk, our manager, to integrate everything and don't overwork. Also, I would like to show you guys this one. It's a little expensive here in United States. It's around 30,000. This one it's really helpful for the hygienist. Uh, the name is Airflow. That help to remove the calculus that the patient have of mouth. We also put this coloration in purple that help us know like in wet areas we have to clean the patient very well. Also, it's better for the gums of the patient because we don't have to do a scaler to to maybe damage the tissue. Also, as I explained, we have the scanner, we have printers now that you can see here. This one is the printer of the patient mouth, and we can also explain this one for patients that need a dental design, or if the patient have any anomaly, we can explain why we are gonna do that. Also, we design in the computer like how big I want to change the teeth, how it's gonna be the bio of the patient. And when I'm talking about benefits of AI in dentistry, as I said, it's gonna improve the diagnostic and the accuracy for the dental office because we can have more access to the dental images, we can show to the patient, we can be more uh, uh, can be more pre precision. Also, the most important thing, reducing human errors. That doesn't mean that the computer doesn't have any errors. And also, the second benefit that I would like to say is the faster treatment because you can diagnose it better, treatment planning the patient so quickly, and with the procedures, as I said, we can use this machine to place the implants. Also, we can scan the patient and let him know where is the cavity. And the third one is gonna be the cost efficiency. Um, this one help to do the checkups, the diagnostic process, and also it's better for the patient understand and reduce the waiting times because before we have to take the impression with the alginate, that is the little thing that we put in the mouth, and we have to send to our lab, and the lab send us back like a 2 or 3 weeks after that. We have back and forth, and this one take a lot of time. Now, if we have this scanner, we can send it to the lab and the lab can make the adjustments that the patient need and send the treatment back. And we can explain the patient another opinion from our lab technician, what he think and what is the best option for this patient. Also, this one help to continuous learning as for the dentist and for the patient because we have the patient data, um, and we can continue improving a little bit more about these scanners. When I'm talking about limitation of AI in dentistry, this one can be a little bit challenging because we have the privacy of our patient in a computer. That means that it's gonna be regulated, and these scanners have our own username and password that we can send to everybody. That information has to be inside of our dental office because we don't want HIPAA complaints. Adaptation barriers, that mean that it's a little bit difficult for the cost of implementing AI technology for the small practices because these machines are gonna be are so expensive here in United States, and some of them can be in a different country. Also, here we have the possibility to pay the machine like with payments. Um, Also, as I say, ethical concerns, how dentists and management this information of the patients, and also the future of AI in dentistry. Um, it's gonna be like an integration of a virtual reality that we can show the patient how it's gonna look, uh, the smile, how we need to improve, and also we need we use at the moment the goggles for the virtual reality also in some dental office to show the patient what's going on or to calm the patient. Uh, Predictable and prevention dentistry. Uh, this one identify potential issues before developing the major problem. That means that we try to management the small issues that we have inside, and we can prevent like a big problem in the future. Also, this is my presentation. As I said, dentist from Colombia, and I live it here in Boston, Massachusetts. I'm working as a dental hygienist. And if you guys have any question about my presentation, or any question about artificial intelligence, I'm very happy to help. I don't know if you have any question about it.
I think no questions from the audience. Thank you so
Oh,
much, Claudia.
thank you.
It was a wonderful
Thank you so much. Yes, I'm
presentation.
sorry again for my voice. I try to do my best. Thank you. Have a nice day. Bye.
So I present today's last presenter, Dr. Raj Arshi H from India. She'll be delivering a presentation on unusual occurrence of myelomatous pleural effusion in extramedullary relapsed multiple myeloma, a case report. So over to you, Dr. Rajashri. Can't hear you. Have you started? We can see your screen. Rajarshi, are you there? Like, can you hear me? Rajarshi, yeah, yes, please start. Rajarshi, we can't hear you. We can see your screen. Is there some technical glitch in audio?
Hello.
So, our next speaker, I think there's some technical glitch. Let me call our next speaker, Dr. Iskandar Chaudhary. Dr. Chaudhary, can you introduce yourself, please?
Oh, hi. Can you hear me?
Yes, yes.
Fantastic. Yes, I'm Iskander Chowdhury. I'm a pathologist working in Blackburn in the UK. And thank you for inviting me today. I have a presentation. I'll just, can I share screen?
Yes, please.
Okay. I don't have the, here I do. Okay, can you now see?
Yes, we can see your screen.
Wait 1 second.
Perfect.
Brilliant. Okay, so I'll commence. My presentation is on digital pathology LIMS implementation in laboratories in the United Kingdom. As you know, that digital pathology is now taking quite a massive step in transforming glass slides to virtual images across the globe, with roughly around 10% uptake in the US and probably around 10 to 20% in the UK from funding received through our government in the UK. And essentially the value of digital is listed here. Second opinions outside a network, interoperability between multiple sites, integration with existing LIMS systems and scanners, improved communication across different sites, and that you can also leverage AI interfaces as well. So my presentation is going to look at how you would implement a digital solution in a laboratory and give you some feedback on software that I've been involved in that can do that very job, provide an end-to-end solution. Now, here would be a typical example of how a laboratory would work. So you would have messages coming in from the EPR system via HL7, then going into the LIMS system, and the one I'll be talking about today is PathHub, which is software I've been involved in developing and also use it as an end user as well. Then using the software, cases would be scanned and then shared, and then along the way they would be tracked and then reported as well. So here you have what an integrated end-to-end solution would look like. So you'd ingest different EPR systems, funnel them through into a cloud environment, and then access, share, and view data via PathHub. The specimen collection and tracking is really important. There's applications that can do that. HiPres is one application that allows you to essentially track the specimen from the time of biopsy. That biopsy, once it's tracked, can be recorded in the pathology LIMS system, which connects to the different EPR systems such as Epic Beaker, Copath, Clinisys,
via HL7. So here's just an example of how the software works. You can see it's got different user groups with a focus on pathologists and clinicians, but also administrative staff. The laboratory test can be configured into the system, and this can link to billing as well. Projects can be set up in the system as well, so it prevents a pathologist having to use Excel spreadsheets, etc., to run their projects. When work comes into the department, you can allocate it to groups or individuals, and the workload allocation can be monitored. A lot of systems now have to have separate tracking, so Cerebro, Vantage, etc., to track sister samples through a laboratory. But PathHub not only does the reporting element, the LIMS element, but also does tracking as well. This prevents you from having to use a second system. Here you can see how records would be displayed in the system, and the urgency and turnaround times of those records or tests. The kind of beauty of PathHub is that you've got an integrated system where you've got clinical history, macro description, micro, where you can write it, and also you've got the viewer. And the viewer will allow you to annotate, share, etc., and really brings everything together. The value again of PathHub is it doesn't stop at the report level, but allows you to build up cases for multidisciplinary meetings and allow you to share digital images in those meetings. The application also has voice recognition. There's various support videos, etc., for people to learn from. So the software has been implemented in multiple hospitals in the UK, and there's interest in the software in the Middle East and also in the USA as well. One of the advantages is that the IMS systems that focus on the images have to integrate with LIMS systems, and to create that connectivity seamlessly is difficult given the way IMS systems work. So PathHub, in a way, it fills a gap in the market by providing both solutions. Another really important aspect of this is that it's vendor agnostic. So you can see here it can ingest different scanner kind of scanner types from different companies and different file formats. I've taken the liberty just to remind the audience of the different scanners that are in the market, and ones that you can procure separately or you can procure through a LIMS system like PathHub, and they would integrate every aspect for you. So if you had this working within your kind of department and laboratory, you can then also connect workload allocation and integrate to your slide printers and do tracking through this system as an addition. So here you can see 3D Histech. It's one of the well-known scanners used widely in the UK, P1000 and P400. Gained traction over the last few years because it can do high volume scanning. So a typical hospital in the UK would do maybe up to 500 to 1,000 slides a day. So large volumes of slides going through the scanner. We also have Hamamatsu, their nanozoomer, Huron, which you may have heard of, Leica, one of the market leaders, and then we have Roche, who have a plethora of equipment, but have also got digital equipment as well. Some less known names here, maybe more for microscopes than actual digital scanners, are listed as well. And I'll be happy to share this PowerPoint with you. Philips were one of the earliest adopters of digital, their ultra-fast scanner in Telesite, with the image management, etc. They built a closed system that other people could not ingest their images, and they're now moving away from that, the iSyntax image. And they've lost some traction because of image quality and cost attached to the Philips product. The difference between PathHub and IMS systems is that IMS example would be Sectra, will help support pathology department, but won't cover one of the big governance issues within pathology, and that is picking up the wrong slide for the wrong case. So within IMS, when you log in, you've got to put the details in, pull up the image, and then correspondingly have the same case opened in your LIMS system. So whilst IMS is great at viewing images, it doesn't work well if you're trying to have a single solution that is not going to be of clinical risk. Inspirata is just another example of a company with an IMS system, and it's been recently bought by Fujifilm. And these two companies, Sectra and Inspirata, essentially they reflect the growing drive of PAC systems to get into the pathology market. Carista is another IMS management platform that plugs into different image systems. There's always excitement with AI. I just mentioned a few companies here: iForia, Ibex, and Indica Labs. All have kind of clinically approved suites of AI algorithms around prostate. Some are around breast, and then measuring receptors like ER and PR and HER2. Page was initially looking at a wider IMS stroke AI environment, but now has reduced its, just only recently announced that it's reducing its portfolio to focus on AI algorithms. And Proscia is just another company that works with a wide range of LIS and LIMS systems, as does Visiopharm. So to kind of starting to conclude my presentation, the kind of final elements in your pathology workflow are having good workstations and ensuring that software that is being used is future-proof. So here's just an example of some of the work that PathHub are doing in their release programs and what they've done since their earlier releases of version 6 and version 7. So just some clinical suites in terms of lungish and another area, non-small cell carcinoma and PD-L1. This is a list of key requirements that you would need for integrations in the sector. You can see that it pertains to the Gulf states and Middle East for some of the kind of specific areas that you need to look at, and it's a checklist of what needs to be considered. This is just about the company involved in producing PathHub and the actual accreditations of that company. So that comes to end of my presentation. I'm happy to take any questions. Would that be okay, Dr. Seema?
Yeah, so I think no questions from the audience, and it was a really wonderful presentation.
Oh,
So
thank you.
yeah, introduction, how understanding how LIMS can be integrated to the digital pathology and what are the uses. So understanding makes it work with it easier, and yeah, so it is actually nice. So one of the thing which is a problem sometimes, so putting the wrong report in wrong case sometime, because there are so many forms and slides. So I think that you have mentioned is clearly eliminated here.
100%, yeah. So essentially, what people are doing is they're getting the reference number from one part of the LIM software and putting it into the IMS. You wouldn't have that. And then the other aspect, I think what's important is that, typical department can have maybe 15 software, one doing quality documentation, one doing tracking, one doing rotas, one doing LIMS, one doing IMS, and you've got to try to get them to all talk to each other. The PathHub solution deals with that problem.
There's some internet issue. Can you check your internet, please? Yeah, you were sharing very useful information. There's some internet issue with.
Oh, hi. Yeah, sorry. Did you?
Yeah,
I don't know how much of that you caught.
No. Yeah, can you? Yeah, it was all gone. You were not audible.
All right. So I'll just repeat that. I was just saying that the PathHub system, the beauty is that it also integrates with printers, so cassette printers, slide printers. It does the full tracking for you. Quality documents can be uploaded to it. So, rather than having 10 pieces of software, trying to integrate them is an all-in-one solution. And it's one that, it's great to share to this audience, and one that I think will make massive efficiency savings to departments.
And regarding the clinical details and macroscopy, so is the clinical details, they are just typed by the staff in the, or they are from the, will there be any forms still?
Yeah, so generally there should always be a form with the specimen, just because the specimen is physical. But from the EPR system, you could do an electronic request, print out that request as well. It would go automatically into our system. For macros, the system does have a little camera, so you can take a picture and put the images into the report and into the system, and also into the report as well.
Okay, so regarding the clinical information, is the radiological information also accessible through this route?
It is, but it would be more linking in with previous reports. So you just have to connect to the EPR system and then pull that information across. But absolutely, yeah.
Yes, really sounds fantastic.
Oh, thank you.
Yeah, fulfills all the requirements which is actually required for daily reporting. Yeah.
Thank you.
Thank you so much.
Thank you for inviting me, as I said. Thank you.
So our next speaker is Dr. Rajashri is our last speaker from India, and we missed her because of some technical glitch. So she'll continue now. Dr. Rajashri.
Can you all hear me now?
Yeah.
Yes. So I'm sharing my screen.
Yes.
So is my screen visible? Hello?
Not yet. No, you can't see your screen now.
Can someone please share my PPT from the organizing team? That would be very helpful because I'm logging in from another device.
Your team will share the PPT.
Thank you very much. So the screen is visible now?
Yeah, screen is visible, and you can tell next to change the slide.
Yes, ma'am. Okay, so I will be presenting a case of myelomatous pleural effusion in a known case of multiple myeloma with extramedullary relapse. Okay, so next slide, please. Extraosseous involvement in multiple myeloma, that is involvement other than the bones, is approximately in 5% of the cases. But considering the load of the multiple myeloma cases, so this is a huge number. Extraosseous involvement, particularly third spaces, includes the involvement of pleura, peritoneum, pericardium, and CSF. All of these are third space involvements, and they are quite unusual. Now, what we call as myelomatous pleural effusion is the involvement of pleural fluid by the myeloma cells, that is the plasma cells, atypical plasma cells in the pleural fluid, which is a rare complication. And even though it is rare, it is the most common among the third space involvements, which happens less than 1% of the cases and usually occurs later in the course of the disease or during relapses. The most alarming part of this is that it is associated with a poor prognosis. Now, how do they arise? Now, there are possibility of three mechanisms. First is the direct infiltration from the adjacent chest lesions, or there may be tumor invasion of the pleura, which we call as hematogenous spread, or the lymphatic blockage, which involves the mediastinal lymph nodes. Now, the reported incidence of multiple myelomatous pleural effusion is less because there are only case reports and descriptive studies. So, with this background, I will like to share our experience. Next slide, please. So, we had a 55-year-old male patient who is a known case of multiple myeloma, IgG lambda type, ISS code 3. He had already been diagnosed with multiple myeloma in 2021 and had been receiving treatment from January 2022. Had received 10 cycles of VRD and 5 cycles of palliative radiotherapy over the left 10th and 11th week. He presented with SOB on exertion and gives a history of recurrent pleural effusion, which required pleural tapping twice in the last 1 month. He presented to us this year in the month of May. Now, chest, we had left decreased breath sounds on the left side and bilateral coarse clefts. His previous CT during the diagnosis of multiple myeloma showed metabolically active bone lesions, which involved the vertebrae, pelvis, ribs, sternum, and humerus. Now, currently after admission, we did an HRCT, which showed moderate pleural effusion on the left side and an ill-defined infiltrating mass along the left lower lobe, which is shown by this black arrow. We did a PET scan, which showed active residual infiltrative mass in the same location with the resolution of all the previous musculoskeletal lesions. Next slide, please. Can I have the next slide? So these are the relevant biochemistry and hematological investigations during admissions. If we go by the CRAB criteria, we can see that there is only anemia. Total protein was normal. There was no derangement of albumin globulin ratio. Creatinine was also normal. Calcium was normal. That's 8.4. Now in urine, we had raised 24-hour protein, that is 1.4 grams. Others, we did serum protein electrophoresis, no M-band, SFLC ratio was normal. None of the immunoglobulins were raised, but the beta-2 microglobulin was high. We thought that let's go for a bone marrow and let's see what is there in the bone marrow. Bone marrow was normal with 6 to 8% of plasma cells, and they were all positive. We did a FISH for myeloma from the bone marrow, which was negative. So from this primary investigations, whatever data we have right now, we can only see that the beta-2 microglobulin is high, along with 24 hours high urinary protein. Next slide, please. Can I have the next slide? Thank you. This is the pleural fluid which we got. It was hemorrhagic in nature, with low glucose, protein was raised, and LDH was very high. ADA levels were not raised, with a high cell count. You can see that almost all the cells are atypical plasmacytoid in nature, along with there were plenty of RBC. So considering the protein and LDH, we classified them as exudate. Next slide, please. We did a cell block from the pleural fluid, and you can see the images. The left side shows the pleural fluid cell block H&E plane, and the right side the ISC. So what we got in the cell block were there were atypical plasma cells in a fibrinous background, and ISC was done, which was positive for CD38, MUM1, CD79A, and there was lambda right chain restriction as shown in the ISCs on the right side. Now we were lucky enough to have the patient in hemodynamically stable condition, allowing us for a pleural biopsy. Pleural biopsy was done, and it showed atypical cells with plasmacytoid morphology, and the IC was done, which was positive for MUM1, CD79A. Ki67 was high, 60 to 70%, and it was negative for CD20, WT1, CK, and had similar lambda right chain restriction. Next slide, please. So this is the pleural fluid. The first top image is the H&E. Second one is the MUM1 slide and the lambda right chain restriction, followed by the Ki67. So after all these investigations, we diagnosed that the patient is having an extramedullary relapse of multiple myeloma as a chest wall mass, along with myelomatous pleural effusion. The patient was put on DCEP regimen, that is dexamethasone, cyclophosphamide, etoposide, and cisplatin. But the cisplatin was replaced by bortezomib due to renal dysfunction, because on HRCT whole abdomen, it was seen that the patient had small cystic SOLs in the kidney, though the corticomedullary junction was not lost. Still, for a safety purpose, we replaced cisplatin with bortezomib, and he is still currently doing well, undergoing follow-up once every month. He just came to us in the month of November. There has been no complaints from his end till now. Next slide, please. So we'll come to the discussion. Pleural effusion in multiple myeloma are not that uncommon. About 6% of the cases are there, but it generally occurs as a part of a coexisting illness, of which the most common is cardiac failure, which is due to amyloidosis. There can be pulmonary embolism, pneumonias due to less immunity, nephrotic syndrome, or a second malignancy. Now, with the advent of all these new drugs, therapies for multiple myeloma, the frequencies of extramedullary diseases have increased. The pathogenesis is proposed to be these prolonged survival of myeloma patients has led to the development of more aggressive clones, which do not need a bone marrow microenvironment for survival. So they move out and they invade the extramedullary organs or tissues, which leads to the development of extramedullary diseases. Now, the hypothesis of pleural effusion disease in multiple myeloma can be because local invasion or maybe hematogenous spread, which leads to seeding of the pleura or pleural fluid with plasma cells. These plasma cells are atypical in nature and they produce large quantities of immunoglobulins, which leads to raised colloidal osmotic pressure and also reduced normal absorption, which leads to pleural effusion. Now, it has been seen from the literature so far that the most common immunoglobulin initially reported was IgA, which was associated with myelomatous pleural effusion. But the recent data have showed that IgG diseases have become more common. They have an equal gender distribution and is generally hemorrhagic, more commonly affects the left side. Next slide, please. Now coming to the diagnostic part. It may be very difficult to diagnose plasma cells, which are atypical in nature, from the pleural fluid if the quantity is very less, because they can be very easily confused with reactive mesothelial cells. And there can be serous effusions which are exudative in nature due to Hodgkin's disease, carcinomatosis, or tuberculosis, all of which may contain plasma cells, but they are all reactive in nature. For this, a diagnostic criteria was established way back in 1994, which postulated that there should be demonstration of monoclonal protein in the pleural fluid electrophoresis and detection of atypical plasma cells in the pleural fluid, followed by histological confirmation with pleural biopsy, either when the patient is stable or during autopsy. Now, cytological identification of malignant plasma cells or atypical plasma cells is considered the hallmark for diagnosing a pleural effusion to be myelomatous pleural effusion. When will we suspect that myelomatous pleural effusion can be there? In cases of increased cellularity, highly cellular, and the presence of all atypical types of plasma cells, which includes both immature ones and atypical ones, binucleate, trinucleate. But if the plasma cells are almost normal looking in nature, then the possibility might be a bit less. Now, why are there so less reported studies of why there are so less studies reported on myelomatous pleural effusion? This is because of its low incidence and the technical limitations are there. The imaging or ancillary studies, or when they relapse, the patient is so weak, so debilitated that ancillary studies cannot be there. And also, routine ancillary studies for evaluation of in known cases of myeloma means if I am having a pleural effusion, why will I generally go for extended immunofluorescence or is protein electrophoresis from the pleural effusion? So these are the reasons. Next slide, please. Good help will be from the radiological aspect. But the problem with pleural effusion and pleural involvement of plasma cell is that the pleural infiltration is patchy in nature. We cannot have a specific area, a diffuse mass forming lesion is not there. It's patchy. So if we want to get a biopsy from there, very difficult because significant abnormal signs on CT will not be there. We are lucky enough that there was an infiltrating mass. So pleural biopsy under thoracoscopic video guidance has improved a lot of diagnostic dilemmas, and it is said to have a diagnostic sensitivity and specificity of around 100%. Okay. But why are we stressing on myelomatous pleural effusion? Because it is an independent poor prognostic indicator with a reported median survival of 2.8 to 4 months. And why is there a dismal outcome? Because the patients generally have a higher ISS stage, higher beta-2 microglobulin levels in the blood, and multiple extramedullary sites of infiltration. And there are high frequencies of high-risk chromosomal abnormalities like del17p and translocation 414. Unfortunately, luckily in our case, we only had our patient with high level of beta-2 microglobulin. No other multiple sites, no chromosomal abnormality. And also we have to remember that these patients are usually resistant to treatment and often relapse in spite of aggressive chemo and radiation. So what will be the line of action in this case? Response rate being similar to other extramedullary disease, and most patients generally go for a proteasome inhibitor, that is either bortezomib or carfilzomib type therapy. Now, why are they not responding? Because if it is localized to the pleura, these drugs do not achieve that required therapeutic concentration in the pleural cavity. So it is difficult to eliminate all those difficult malignant plasma. Now, there are some reported cases in which they have tried intrathoracic injection of interleukin or interferon, but that is still not yet official. Next slide, please. So I'd like to conclude by saying that the heavier tumor burden and more advanced disease conditions are responsible for dismal outcome in myelomatous pleural effusion. Though they are treated similarly as one with poor cytogenetics and high risk groups, the response is not very good. So we need to evaluate the etiology of pleural effusion in any hematological malignancy, so that we can say whether it is involved by the primary disease or there are secondary causes, because the prognostic and therapeutic implications differ. Diagnostic thoracentesis using ancillary studies and video guided or radiological assistance is important, and the available literature is limited by investigators focus primarily on diagnostic and treatment modalities of multiple pleural effusion, myelomatous pleural effusion, but still now no consensus has been achieved. And the role of high dose chemotherapy with stem cell rescue is not very clear, because there is still debate going on whether what is going to happen, or how are we going to approach these cases, but may be considered in appropriate patients where they are supporting. Okay, so this will be my end. Thank you. Can I have the next slide, please? Okay, thank you very much.
Thank you, Dr. Rajeshri. Any questions from the audience? I suppose no questions. So thank you so much it was a really wonderful case, very knowledgeable. Thank you.
Thank you, everyone.
I also thank everyone present here who has attended these sessions. And this is the closing day of the joint Emirates 3-day UCG conference. I thank you, the organizers, for taking this task of uniting people from all over the world in different time zones and bringing them together. And it had been a really difficult task for them, and to coordinate with them, and making it a wonderful event, knowledgeable. It is so resourceful, and uh, inviting me as a chairperson. I'm really thankful to the organizing team. Dr. Garima, Dr. Balraj, you want to say something?